dignitaries, faculties, and all the postgraduates, a very warm good evening to one and all. On account of Andhra Medical College's centenary year celebration, we, the Government Hospital for Chest and Communicable Disease, Visakhapatnam Andhra Medical College, in association with Apollo Hospitals, Hyderabad, cordially invite everyone to a seminar on updates on thoracic organ transplantation with special reference to lung transplantation. First, I would cordially invite our Superintendent HOD, Department of Pulmonary Medicine, to give a small intro about the session. I welcome you to the stage, sir.
Good evening, everybody. It's an immense pleasure for me as a superintendent of this hospital to organize this very CME on the ECMO as well as lung transplantation. At the outset, I deeply welcome and thanks from my bottom of the heart for the entire Apollo Hyderabad team. Give them a big hand. Actually, they have come forward to all the way from their end and made their own arrangements in this hospital in order to give this excellent lecture about the ECMO and lung transplantation. And they have taken the exceptional pains also in arranging this direct talk as well as the question and answer session from our Chaitanya, who is happened to be our postgraduate and taking a training program at US about the lung transplantation. So, without wasting time, I would like to give you a small introduction about this lung transplantation. Actually, Apollo has been the frontier in the lung transplantation and any transplantation of the organ. When I worked with them in 2016 or 15, they already made a big registry of cases which are requiring lung transplantation, and there's a great amount of a team like transplant coordinator also who is registering all the cases in this state as well as other states also, and they are coordinating with Avayavan or Jeevandan program also, and they are doing a wonderful program. I think we should learn a lot of things from them in this CME also. So coming to lung transplant, next slide please. So the first lung transplant was done in 1963. The recipient only survived about the 18 days only. The first successful heart lung transplantation was done in 1981. Single lung transplant was done in 1983. Double lung is in 1986. So there's a various types of transplant programs also there. And more importantly, unlike the other organ transplants, everybody is having a grim picture after the post-transplant. But I think this program is going to give us the in-depth knowledge about how to manage the patients even after the transplant also by our immunotherapy madam also, Dr. Nirja. Next slide. So the first heart lung transplant in India was done by Dr. Cherry and team in 1999, and the Janesh Thakur performed the first successful lung transplant. Next slide. So since then there has been a gradual increase in the lung transplant, especially since the 2000 year and then 2006 approximately, around 4,500 transplants are done, and among which 200 were done in India. Next slide. According to data from the Health Source Administration, transplant performed by the organs, these are different things, and lung is totally now picking up in numbers. Next slide. Next slide, yeah. So this is the donor rate actually from India and abroad. I think with the cadaver donor transplant program, I think we're going to have more number of them also. So various programs like single and double lung transplantation. So next slide. So the endpoint of lung transplant is no more than just a rehabilitation. So it has to be stressed and impressed upon every case. And I wish you all the best for this wonderful program. Thank you. Thank you very much for giving this opportunity. Thank you.
I request Dr. M. Neeraja, Consultant and Head HOD, Department of Transplant Immunology, Apollo Hospitals, Jubilee Hill, Hyderabad, to give her session on HLA in organ transplantation. I welcome you, ma'am.
A very good evening to all the delegates present over here. First of all, I would like to thank Dr. Naresh sir and Government Chest Hospital team to give me an opportunity to present before you. I am consultant and head transplant immunology. I have been used to speaking in lot of kidney sessions, liver sessions and all. This is my first presentation about lung and heart transplantation. I don't know how much justice I can do about it. So transplantation is the act of, am I audible? Yeah. So transplantation is the act of transferring the cell tissues or organs from one side to another, and graft is an implanted cell tissue or organ. The person who receives the organ is the recipient and the one who donates is the donor. So the basics of transplant immunology lies in a word called HLA, the human leukocyte antigen, and the alloantigens elicit both cell-mediated and humoral immune response. So the alloantigens elicit both cell-mediated and humoral immune response, and recognition of the transplanted cells, which are self or foreign, is determined by polymorphic genes, that is HLA. So HLA basically is present in the major histocompatibility complex, and these are the genes whose alleles encode polymorphic cell surface glycoproteins involved in the antigen recognition and presentation. So MHC match should be there for any organ transplant, whether it is kidney, heart, liver or lung. As per the European Transplant Act, there should be a minimum of 6/6 antigen match between patient and donor. However, for heart and lung transplant, this is very difficult because the donors are everyone are cadaveric donors. We can't do live lung or heart transplants. So there is very few donors, and getting a full match donor is highly impractical. So as Sir said, the first organ transplantation of kidney was done in 1959, liver transplant in 1967, and the heart transplant in Cape Town in South Africa in 1968. Now the question is, why the organ transplant is so difficult and why all of us should break our heads to do the transplant? So the answer is, the organ transplantation is difficult because of the HLA antigens which are located on the cell surface. And these HLA antigens, which are also referred as MHC, plays an important role in the recognition and discrimination between self and non-self. So where is this HLA present? The HLA is basically present in the short arm of chromosome number 6, and its essential role lies in the control of self-recognition. So basically these HLA are of two types, class 1 and class 2. The class 1 genes are HLA A, B and C loci, and class 2 or the D region is DR, DQ and DP region. So these class 1 genes are virtually present on all nucleated cells, whereas class 2 are restricted only to the specialized cells of the immune system, the macrophages or B cells. Now, why HLA is so important is because they are highly polymorphic and polygenic, thus leading to transplant rejections. So with the advent of newer technologies, in the earlier days, the HLA matching was done by low resolution or serological methods, but nowadays it has been replaced by a gold standard next generation sequencing. So as the technology advances, the number of new HLA alleles which are discovered is increasing slowly, and more than 20,000 HLA alleles have been discovered till now, and the counting is still going on. So any cell displaying some other HLA type is non-self and is seen as an invader by the body's immune system, resulting in the rejection of the tissue which is bearing those cells. Now, how does this HLA is inherited? As per the Mendel's law of genetics, which we had studied during our school time, the law is if suppose there are two siblings in a family, a child will inherit one set of HLA from father and the other set from the mother. So the set which is inherited is called as a haplotype. If there are two siblings, as per the law, there should be a 25% full match chance, or 50% of half match, and 25% no match. So this is the law which we followed in most of the solid organ transplants, especially in kidneys when we do for live transplants. So what are the factors which are favoring the allograft survival? The basic one which you have to follow is blood group compatibility. So whenever we are doing a kidney, like the cadaver transplants, the blood grouping should be same between the patient and the donor. Then there should be a HLA compatibility, which I said for heart and lung it is very difficult. And then the procedure what we follow is we have to do HLA typing and tissue matching. So what does HLA identify? It identifies the HLA antigens which are expressed on the surface of the leukocytes. So the applications of HLA typing is mandatory for any organ transplant between patient and the donor. A 100% match is considered ideal for any transplant, but this is not possible for heart and lung. So the class 2 typing is very important for successful long-term outcome of the transplant, and this applies very much to the lung transplant. So prior to a transplant, we do a test called a cross-match test, which is performed between the donor's lymphocytes and the patient's serum to check for the presence of preformed antibodies in the recipient, which are reactive against the donor antigens. So the laboratory tests which are being done before a transplant, which is also called a pre-transplant workup, is ABO blood typing, tissue typing, and then which is called a lymphocytotoxicity test. This is the basic HLA test which is followed for all the organ transplant, and it is called complement dependent cytotoxicity assay. And that is followed by mixed leukocyte and reaction. This is nothing but the PRA. So any patient who wants to undergo a heart or a lung transplant has to register in Jeevandan. And when they are registering in the Jeevandan, the test what we do is called panel reactive antibody test. So the panel reactive antibody test is basically done to detect the levels of sensitizations in any human, which I'll discuss in the following slides. So what are the methods by which we do typing for HLA? This could be, as I said, serotyping, the Sanger sequencing of the amplified products, and the most commonly used in all HLA laboratories throughout India and abroad is the sequence-specific oligonucleotide probe typing, which is an intermediate or low resolution typing. And now the latest one is next-generation sequencing typing. So the importance of HLA transplant is in organ transplantation, hematopoietic stem cell transplant, parenting testing, and disease associations also is shown by this HLA typing, like celiac disease association or HLA B27 with ankylosing spondylitis, and many different, like suppose if a patient is a HIV patient, if he is not responding to ART therapy, then he will be having B51 or B52 genes. So there are many approaches for HLA typing other than the organ transplant. So as I said, what does the resolution means? Like since I said HLA is highly polymorphic, the nomenclature is how when we give a report to the clinician, they should understand what we are giving. So this is how the pointer is not there, sir. That's okay. I'll tell you. So this is how a HLA is being denoted. The main HLA, A is the gene. It could be either A, B, C, DR or DQ. Then that is followed by the allele group. So first when we give a report, it is HLA-A followed by the allele group, and then the protein, and then followed by a field which shows the synonymous DNA substitution. So when we do bone marrow transplant, this NGS is mandatory. Even for heart and lung, it is mandatory, because if there is a mismatch in the third digit, which is telling what is the synonymous DNA which is present, because of this mismatched DNA also the rejections are going to happen. So as clinicians, when you are ordering for HLA typing, please write that do HLA by high resolution typing, because intermediate and low resolution you get lot of ambiguity, and there will be a disparity in the last field which shows differences in the non-coding region also. So this is how a HLA report appears for a patient and donor when we issue the report. So this I don't want to go deep into the procedures. So what we do is we extract the DNA from the patient sample. When we do HLA, we collect the sample in EDTA tube. We extract the DNA from the whole blood, and that DNA is subjected to PCR with a known target, like A for A, B, and C, and DR loci, and then denaturation of the biotinylated product, probe hybridization with a group or allele-specific probes. Now, how do you know what patient is having which HLA? So after the PCR, we subject it to an instrument called Luminex, in which you have a database which is already built in it. So when we do HLA typing of the patient, our genes will go and align with the already existing database, and then finally it will give whichever is the close match. So what happens in next generation sequencing? It is a massive parallel sequencing technology that offers high throughput, scalability, and speed. The technology is used to determine the order of nucleotides in the entire genome or targets of DNA or RNA. I think you might have heard what is whole genome sequencing, the sequencing of the entire gene of a particular patient. That's how a lot of studies about COVID-19 and all had happened. So NGS offers to detect novel or rare variants with deep sequencing. We can identify rare variants like disease-associated HLA genes, which may be rare today, but in future it can become a common gene responsible for a particular disease. So 4 fields of resolution is achieved by NGS, and it resolves allele ambiguity in exons, thereby achieving better tissue compatibility in transplant. So during the COVID-19 outbreak, we used to receive a lot of samples from KIMS hospital in Hyderabad, because we were the only ones who were doing next generation sequencing. So they said they had sent around 50 lung transplant recipient patients EDTA sample. This was a pilot study which we did, yet to be published. So, and out of the 50 lung transplant recipients, there were 34 patients with interstitial lung disease, and 16 patients with post-COVID-19 lung fibrosis. So these patients were included in a study from January to August 2021, when the COVID was at a peak. So in our study, what we observed was there was a male preponderance among the recipients, with most affected age group being 51 to 70 years. And we did HLA typing of all these 50 lung transplant patients, and we found that the most frequent HLA alleles in 34 ILD patients were HLA A11O1O1. Almost 25% of these patients had these genes, and in class 2, the most common one was DPB1O2O1O1. So what we suspected is the patients who had A11 and DPO2 are more prone to progress to interstitial lung disease, and they were presented for this lung transplants. And the most frequent HLA alleles in 16 post-COVID lung fibrosis patients was HLA-DQ. This HLA-DQ plays a very important role in the rejection for post-transplant. And the DQ gene, what we identified was DQB1, 03, 02, and 01. So we concluded from our study was DPP1 O2O1 was found to be more prevalent among ILD and DQB O3 O2O1 among post-COVID lung fibrosis, suggesting that the increased frequency of class 2 HLA alleles may contribute to identify potential markers of susceptibility to ILD and post-COVID-19 lung fibrosis. So this is just a pilot study. We have to do few more studies. So I think when we do lung transplant massively in Vizag, we can do a pilot study from here also. So we have identified a lot of new alleles in our renal transplant and liver transplant patients by NGS, and these were published in international journals called HLA Immune Response and Genetics, New Allele Alerts. So these two were the first one was from a renal transplant patient where the son was the donor to a mother. So when we did HLA typing, a new allele called B44256 was identified, and from mother he had inherited, the son has inherited from the mother. And this was responsible for end-stage renal disease, due to which he progressed to CKD. And I think even for liver, there are a lot of unknown reasons why a patient goes into a liver failure or a lung failure. So these unknown reasons we can find out by doing a whole genome sequencing. And if there is a mutation in any part of the gene, then we can identify and we can say that this could be the reason for the mutation why a patient has developed that particular disease. Now the question is, does MHC HLA matching prevent rejection? It reduces the rejection, but there are still minor histocompatibility antigens, and MIHA are probably polymorphisms affecting peptides in the grooves. But we cannot MHC match most of the grafts, as I said, because of too much polymorphisms, too little time, and too few donors. So that's why there is a need for immunosuppression. Now, why HLA is most important or significant in transplantation, and which HLA is more important post-transplant? So among them, HLA-DR mismatches are most important in the first 6 months after transplantation. HLA-B effects emerges in the first 2 years, and HLA-A mismatch have a deleterious effect on long-term graft survival. So that's why we insist on HLA typing, even if the donor is a cadaveric or not, for post-transplant monitoring, so that we can expect like which mismatch is more important for rejection after the transplant. So the main important problem with the transplant is the development of HLA antibodies. Now, how does these HLA antibodies develop? They develop because of mainly 3 reasons. Any patient who has a history of sensitization due to blood transfusion, in females, the multiparous women, because 15 to 25% are directed against paternal HLA genes inherited by the fetus, and any patient with a history of blood transfusions, especially platelets and lymphocytes, or response to viruses. So after the transplant, since the patient will be under a lot of immunosuppression, he will be prone to a lot of bacterial and viral infections like CMV, Epstein-Barr virus or BK virus, and bacterial infections like pneumocystis and all. So sensitization remains a major challenge in organ transplantation because its presence can restrict the access to organ transplantation by limiting the available donor pool and increasing the waiting time, thereby increasing the risk of waitlist mortality and morbidity as a result of progression of underlying disease. So how do you screen the antibodies? There are different methods in which you can screen the antibodies. So the main purpose is to detect antibodies in the recipient serum that react with the HLA antigens of the donor. So we know what HLA type the person is, but we don't know what antibodies they have to other HLA types. So the most commonly, which is a cross-match which is used all over the world, is complement-dependent cytotoxicity assay. But this is the lowest antibody screening method because the sensitivity is too low. So the different approaches for CDC, flow, DSA, crossmatch, and the donor-specific antibody is mainly detected by Luminex assay. But the important problem for detecting of these antibodies is the interference with the drugs the immunosuppressive drugs which are being given to the transplant patients for avoiding the rejection. So that's why we don't do CDC for heart and lung transplant. We do only DSA by Luminex method. So if a patient is highly sensitized and he has applied to Jeevandan for allotment of the organ, either heart, kidney, lung or liver, we have to screen them by a mixed antigen screening assay to find out whether the patient have anti-HLA antibodies or not. And the important test to do is panel reactive antibodies. So this test is to find out to what percentage of population does the patient have antibodies and what is his chance of getting a compatible donor. Then the latest antibody detecting method is single antigen assay, in which we find out what are the antigens against which the patient has antibodies and which donors should be avoided. Yeah, so how do you do the risk assessment? If any patient is positive for complement dependent cytotoxicity assay, outright we reject the donor. Even if he is a cadaver, we tell the patient to wait for few more days because on-table rejection will be there if CDC cross-match is positive. So the current positive CDC contraindication to transplant, as I said. So and then we do another test called donor-specific antibody test. And if the MFI values are very high, we suggest the clinicians to follow the desensitization protocols with either IVIGs or plasma exchange. So the presence of pre-transplant antibodies against antigens encoded by HLA and specifically those antigens that are expressed by the organ donor in kidney, heart or lung or liver. So they are highly associated with hyperacute and accelerated rejection. And there are in cases, sometimes these antibodies, if they are present in lower levels, we cannot detect it pre-transplant. So after the transplant, there are some antibodies which develop and they are called de novo DSA antibodies in the recipients post-transplant. And if there are de novo DSA present post-transplant, it is a direct indication of the onset of antibody-mediated rejection. So the advantage is removal of false positive because of antibody binding to non-HLA. So it is not necessary that only HLA antigens are responsible for post-transplant rejection. There are some non-HLA antibodies also called MIC-A, MIC-B, anti-endothelial cell antibodies and all. So how do we interpret the result is, we do measure the mean fluorescence intensity. So if the MFI value is more than 1000, then we say that the patient has developed donor-specific antibodies and the chances of the rejection post-transplant is very high in such cases. So we follow the British Society of Histocompatibility guidelines to interpret the levels of antibodies. So if it is less than 1000, then we say that there are no DSA levels. If it is less than 2000, the patient is at a minimum risk of hyperacute rejection due to low-level donor HLA specific antibodies. And if the MFI value is more than 5000, transplant veto apart from exceptional cases, and further testing like CDC or Luminex assays has to be considered in cases to further refine the risk profiles. So as I said, the DSA has got a lot of effect on the patient's survival post-heart or lung transplant. As you can say in this graph, patients who did not have a DSA has a longer survival time post-transplant, and patients who had high levels of DSA had rejection, and the survival rate is also very less. Like within few months, they die because of these antibody-mediated rejection. And out of these HLA, ABC, DR, DQ, the DQ is the most dangerous, and DQ, DSA are most prevalent post-heart transplant and even in lung transplant patients. So what is PRA test? It is a screening mechanism to determine the HLA antibody profile of potential transplant recipients. So what is the frequency with which you have to screen the patient when they have gone for Jeevandan? You have to screen them either monthly or quarterly of the recipient sera with a panel of HLA typed cells. So sensitization of the recipient is expressed as the percentage of serum reactivity with total panel. High PRA is indicative of highly sensitized recipient, one who is at risk of early graft loss. So we express this PRA in the terms of percentage. So in the result, when we say that the PRA levels in a particular heart or lung transplant patient is 20%, it means that he has 80% of chances of getting a donor. If his PRA levels are 80%, then there is only 20% of his chances of getting a donor. So this test is very, very important for a person who wants to register to Jeevandan for cadaver transplant. And there is calculated PRA also. So it detects the percentage of donors with unacceptable antigens in the donor pool. So what matters clinically? How easy will it be to find a donor for my patient who is awaiting heart or lung transplant? So as I said, if CPRA is 10%, then 90% of the donors would be a match. So the latest antibody detection method, what we follow in Apollo is single antigen bead assay, which is used for virtual cross-match test. So here it detects the quantitation of HLA antibodies, in which there are beads called Luminex beads, which are coated with say 1 antigens. So they will, now we get a lot of questions from the clinician, madam, the kits are being developed in US or in other countries. What is the guarantee that the kits are covering all the HLA alleles which are most frequent in India? So the same question we had asked them, they said that they cover the most common HLA antigens prevalent in Indian, South African, Hispanic and Caucasian population. So there is no doubt that most of the HLA alleles which are prevalent in India are covered in this assay. So each bead is coated with 100 individual HLA specificities, and based on the intensity of the fluorescence, we suggest the clinicians to go ahead with this desensitization protocols. So how do we do a virtual cross-match? We generally, whenever we get a cadaver transplant in the midnight, the question is first, is the patient sensitized or not? If he is sensitized, to what level are the level of antibodies, and what is the success of the transplant? So in the midnight, we do HLA typing of the cadaver donor. So we have to collect the EDTA samples from the cadaver and plain sample from the patient. So we do single antigen bead of the patient and donor HLA typing. So we extract the DNA from the cadaveric donor sample and we do HLA typing. So here I'll just want to discuss case on antibody-mediated rejection due to DQ antibodies, but this was in a kidney transplant patient, and the same applies even if it is a heart or a lung. So this was a 28-year-old male CKD patient who had cadaveric transplant, and his history of sensitization is he had undergone 3 units of blood transfusion. So as I said, any patient with a history of blood transfusion or females with a history of pregnancies, or many of them go for second transplant. So all 3 come into categorization of allosensitization. So he was presented to a hospital on 20th February 2022. His CDC cross-match was negative. Luminex DSA was also negative. And single antigen beat class 1 was negative, but class 2, the PRA was just 1%. So the clinician said, anyway, madam, this is only 1%, we'll go ahead with the transplant. And the type of antibodies what the patient was having is DQ antibodies. So the transplant was done on 21st February, and the patient was on a regular follow-up as per the protocol. And on May 12th, he was presented with low urine output, and then we suspected it to be an antibody-mediated rejection. So on 19th, we did a virtual cross-match. We repeated this single antigen bead, and to our surprise, his PRA levels came up to 16%, and the antibodies detected were DQ with mean fluorescence value of 5,832. So we did cadaveric donor typing, and what we found was the virtual cross-match was positive. So how do you manage such patients in whom you suspect that antibody-mediated rejection is there? You have to either do antibody suppression and removal with intravenous immunoglobulins and plasma exchange. So as you can see, the thing which I have marked in a red, the patient was having DQ and antibodies, and the donor was having DQ-HLA antigens. So because of the virtual cross-match being positive, the patient has antibody-mediated rejection. So you have to monitor the patients after the transplant for the appearance of antibodies against donor HLA antigens and monitoring the effects of antibody reduction treatments in these patients. The other hazards which could be possible for transplant patients could be the antigens which are expressed in the organ but not on the lymphocytes. So these could be angiotensin type 1 receptor, anti-vimentin antibodies, anti-myosin antibodies, and MICA and MICB are the non-HLA antibodies. So the latest, which is I think favorite of Naresh sir, is the donor-derived cell-free DNA. So whenever you are suspecting of rejection, the first thing what the clinician says, let us do a biopsy and find out from the histopathology report whether C4D staining is positive and the patient is suspecting of antibody-mediated rejection. But I have one question for the PGs. Is it possible to do the biopsy of all the organs? Is it not an invasive method? What is the answer? Yes. So now the new test called donor-derived cell-free DNA has arisen, which is nothing called, it is a liquid biopsy kind of thing where we screen the patient's whole blood for the presence of these donor-derived cell-free DNA in the blood of transplant recipients. It has been proposed as a non-invasive marker for diagnosis of graft rejection. So the premise for the quantitative interpretation of this biomarker is that rejection entails injury. Do you agree or not? So any rejection will result in the injury of the transplanted organ. So this leads to an increased cell death in the allograft, leading to increased donor-derived cell-free DNA into the bloodstream. Okay, now data from several single-center studies suggested that donor-derived cell-free DNA levels in the blood measured as a fraction of total cell-free DNA, and it can discriminate the rejection from non-rejection in the heart, lung, liver, and kidney allografts. Now in a stable heart transplant recipient, the fraction of cell-free DNA originating from the graft is nearly less than 1%. He should not have any donor-derived cell-free DNA in his blood if there is no rejection suspected. So whereas during the rejection, the levels of this donor-derived cell-free DNA is significantly higher. So in stable lung and liver transplant recipients, the level of donor-derived cell-free DNA is higher than in stable heart transplant recipients. So the value is not similar for all the organs. It depends on what type of organ have we transplanted. So, and it further increases in moderate to severe rejection. So, take-home message from my presentation is a dialogue between the clinicians and the laboratory staff on an individual patient basis is essential for correct clinical decision making based on the HLA antibody results obtained by various techniques. So, this is our lab. We have a very small team, only 5 of us, taking care of all the heart, lung, liver, whatever transplants happen in our Apollo hospitals. And I thank you so much for your patience listening. Any questions?
Transplantation, you are doing PRA.
Yes.
Isn't it? Nowadays, what is the rationale in doing PRA for pediatric blood transfusions? No.
So any transfusion will lead to the development of HLA antibodies, whether it is pediatric or adults.
For not so with adults, for adults we are not doing.
No, so PRA is basically mandatory to do for detecting the level of patient's sensitization history, because that will lead to the development of these HLA antibodies. And if a patient is having HLA antibodies, then he is at higher risk of post-transplant rejection. So we always suggest that whoever is going for even for live or cadaver transplant to get tested for PRA, because that is the basic test which detects whether patient has HLA antibodies or not. And I think in, government hospitals, cost also matters a lot. A patient cannot undergo menu of tests going on, spending lot of money in testing. So the basic test what we suggest to all the transplant physicians is first screen the patient for the presence of HLA antibodies by doing a PRA, even if he is an adult or a pediatric patient. We do even for pediatric kidney and liver patients in our hospital. It is mandatory in Telangana Jeevan Dan.
That's what.
Yeah.
If PRA is positive for a pediatric transfusion, can we stop that?
It is
You
not
cannot go
necessary
ahead.
that you should stop it, sir. But you have to change his regimen of treatment. Like you have to increase the immunosuppression strategies to lower these HLA antibodies before transplant. And after the transplant, also you have to monitor for the appearance of these HLA antibodies either quarterly or 6 months, like that. And then.
I'm not talking about transplantation, only blood transfusion, pediatric blood transfusions. Nowadays, they are insisting to go for PRA.
Yes, sir. Because
How
of
rational
these-
it is. How otherwise how they will survive? No departments. No, you cannot go on doing PRAs for blood transfusions, sir.
That's what I see. PRA, it is not necessary that every time you go on doing. Once in 6 months, you can screen the patient or the baby for the presence of development of these HLA antibodies. It is not necessary that everyone will develop HLA antibodies, as I said. So better to screen them every 6 months to find out whether they have developed. If they don't develop, it is fine. But if they develop, it is always better to do the protocol will be different for them, sir.
Okay, thank you.
Thank you so much.
Thank you, ma'am. That was a very informative and detailed presentation regarding HLA typing, antibody screening, and various methods used in it. Now, let us start the program. On account of Andhra Medical College centenary year celebration, GHCCD, in association with Apollo Hospitals, Hyderabad, cordially invite everyone to the seminar on updates on thoracic organ transplantation with special reference to lung transplantation. At the outset, I cordially invite our beloved HOD, Dr. R. Sunil Kumar, sir, to come on to the dais. I welcome you, sir. Next, I take immense pleasure in welcoming our guests of honor, Dr. G. Buchiraju, sir, Principal, Andhra Medical College. We welcome you, sir. Next, I welcome the other guest of honor, Dr. G. Rajendra Prasad, sir, Vice Principal, Andhra Medical College. Welcome, sir. Next, I welcome our special speakers, Dr. P.V. Naresh, sir, who's a senior consultant in the CTVS department, who specialized in heart and lung transplantation, minimally invasive cardiac surgery, and aortic surgery, Apollo Hospitals, Jubilee Hills, Hyderabad. We cordially welcome you to our hospital, sir. Next, I welcome Dr. M. Neeraja, Consultant and HOD, Department of Transplant Immunology, Apollo Hospitals, Jubilee Hills, Hyderabad. Welcome, ma'am. Last but not least, I welcome Dr. B.M.S. Pathuru, sir, Professor, Andhra Medical College, Department of Pulmonary Medicine, Andhra Medical College. Welcome, sir. Now let us start the program with the lamp lighting ceremony. I request all the dignitaries to come over to the lamp.
प्रजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि प्रजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि.
Now I request Dr. R. Sunil Kumar sir, HOD Department of Pulmonary Medicine, to give his opinion on this seminar.
Good evening, everybody. Respected Principal Dr. G. Bucharaj sir, respected Administrative Vice Principal Dr. Rajan Prasad Garu, our Speaker of the today, and Dr. Naresh Kumar, Consultant CT Surgery, Apollo Hospital, Hyderabad, and Dr. Neeraj Madam, Immunologist, Hyderabad, and Dr. Bhushan sir, our HOD newly formed as a HOD, our MD Pulmonary Medicine, and our Dr. BMS Pathadu, Professor of Pulmonary Medicine and in charge of the upcoming DM Pulmonary program in this hospital. The faculty members as well as the other postgraduates and friends. It's immense pleasure for me to conduct this program on behalf of the department in association with the Apollo Hospital, Hyderabad. At the outset, I thank very much the principal sir, who is very, dedicated and down-to-earth man in bringing up the DM Pulmonary Medicine seats, which is in process, and he is in constant pursuit with the NMC also through the sending persons in personally, and also to make that our postgraduate seats enhancement from 14 to 18 also. Actually, he is doing more work than me and myself, my staff, in bringing this thing. Since the beginning of this, inception of the office as a principal, he is totally dedicated to the upliftment of the number of postgraduate seats in all the faculties, all the fraternities also. And he has taken the credit of conducting 40 NMC inspectors at a time, along with our Rajan Prasad Garu, who is happened to be his classmate. The duo is having a disastrous combination in conducting many programs in our hospital, and they got laurels in the DME of AP, and also they are doing a great job in our hospital also. Thank you very much, sir. And Dr. Naresh sir, we met him sometime back in the 2015 or 2000. Actually, he's doing a dedicated thoracic surgeon. Actually, done a lot of surgeries in the Apollo Hospital, Ramnagar, as well as other areas also. And he is trained abroad, and he has done a great work on thoracic surgery. And he came to us almost 2 weeks back to conduct this program in our hospital. We are very, very happy that you came all the way down to this hospital and conducting this, sir, and making us aware about the program of lung transplantation. Thank you very much for taking the initiative and conducting the program also, sir. And I thank Dr. Neeraj Madam, who came from all the way from Hyderabad, and because immunology is very, very important in order to do the post-transplantation program as well as pre-registration program also, and which is very, very important nowadays because a lot of science has already grown up. And thank you very much, sir. Thanks for giving me this opportunity also. Thank you, sir. Thank you.
Thank you, sir. Now I invite Dr. B. Buchiraju, sir, Principal, Andhra Medical College, to speak a few words.
Good evening, everybody. Dr. Sunil, Superintendent, Government Chest Hospital, HOD of Pulmonology, Bhushan, Professor of Pulmonology Patrudu, and my good friend and Vice Principal Dr. Rajendra Prasad, and other faculty of pulmonary medicine and students, and our guests for the day, Dr. Dr. Naresh Kumar and Dr. Neeraja, who will be, and actually I have to first thank the faculty and students of Chest Hospital who have done quite a yeoman service during the COVID times. And this is, I think, after Sunil took over as superintendent, several academic programs have been conducted. I was associated with few of the programs in last 1 year of my tenure. So I congratulate him and the Department of Pulmonology for organizing such CMEs. Recently we also had the journal CME also in respiratory medicine, which was organized here. Tomorrow also we have 2 journal CMEs, both in gynec and radiology. So I'll thank Naresh Kumar and PV Naresh. Actually I was associated with him when he was in Apollo, Vizag, for quite many years when he worked in Vizag. So I congratulate PV Naresh and his team for coming up and giving some academic program, because after the COVID, everybody was very much interested in, not before COVID also, there are a lot of enthusiasm regarding transplant, especially lung transplant. Many times, because I was associated with Jeevandan and brain death declaration in the last 1 decade, many times most of these, especially lungs, are done by very few people. So they are, I can say, waste, probably not utilized properly. So if you create awareness and keep up a registry of the patients, and if you get a patient, probably you can utilize people who are doing transplant in AP or adjoining states, so that more people may be benefited, especially with now improvement in immunology and so many new drugs in preventing the rejection and long-term effects of immunosuppressants. I think we should all be now start having registries of people who need such of these conditions, so that when we have a patient, especially like when we have a donor, we can utilize their service, because the same person can be used. You saw recently in last 1 month, one of the hospitals conducted double donation, organ donation in single patient. So things will be might better. Even though AP is quite low in terms of this organ cadaver organ donation, because it should come from more from neurosciences, because most of these patients are admitted in neurosurgery or neurology. So these people have to be, but quite a good work is done both in Kerala and Tamil Nadu and also in Telangana. So we are slightly in getting these people, but you have to first start registry and also to look for donors, so that some people can be benefited. So with this, I once again congratulate Department of Pulmonology and Apollo Hospital, Hyderabad, for organizing an academic feast today evening. Thank you all.
Thank you, sir. Next, I would like to call upon Dr. G. Rajendra Prasad, sir, Vice Principal, Andhra Medical College, to speak a few words.
Professor Sunil Kumar Garu, your superintendent, your beloved superintendent, and my beloved friend Dr. Bujraj Garu, our guests, Neeraja ma'am and Naresh sir, and our colleague Dr. Patrudu Garu, and my dear friends, colleagues, students, I am very happy to be invited to this August gathering. Organ transplantation, even though I am a pediatric surgeon, is close to my heart. For any subject, for us to understand, my way of thinking is go to the history, go to the roots, how it developed, how organ transplantation developed in the world. You know, a surgeon, famous surgeon, great surgeon, Alexis Carrel, is the person who described the vascular anastomosis. A simple vascular anastomosis technique described by him is the initiation for organ transplantation. You see the number of organs being transplanted every day in and day out all over the world. Millions of people are surviving or living just because a surgeon, a French surgeon, described this technique of vascular anastomosis. For this, he was awarded Nobel Prize in Physiology and Medicine in 1912. One of the very few surgeons who got Nobel Prizes. So I remember him a lot. This point I studied when I am doing my MS General Surgery. I am very fond of those surgeons who got Nobel Prizes because very less number are there, no? So he opened up the field of transplantation surgery. And his field of interest is thoracic organ transplantation. He is the person, along with Charles Lindbergh, devised perfusion pumps, which is the most vital instrument or item to perform organ transplantation. Before we step into anything, we pray the ancestors, we pray to the gods, we pray to the ancestors. Like that, this seminar, I thought by taking their big names, this presentation, this talk will become a huge success. Thank you very much for inviting me. I wish you all the best.
Thank you, sir. Now I'd like to call upon Dr. P.V. Naresh, sir, consultant CTVS from Apollo Hospitals, Jubilee Hills, to give a few words on the session.
esteemed teachers and Patru, who is one of my friend, and he also has taught me a lot, but still I also call him a teacher on the dais. In the first outset, thank you very much for giving me this opportunity to just give a little bit of enlightenment. We are not going to discuss too much on the topic. And just before, when we were discussing with Sunil Kumar sir, we were just telling him at one time when I was 10 years back, when I was in Vizag working with Apollo, we were thinking of doing lobectomies or pneumonectomies or decortication. So within the 10 years and with COVID coming in between, how things have changed is the general awareness of even the governments, that they have known that health is going to be a very important thing which has to be taken care, and individual state governments are doing more and more to improve the health of the community. And when we were discussing here, I just gave him a proposal that maybe within a few months' time, we have the infrastructure here at the government chest hospital where a lung transplant can be performed. So he was a little surprised. Then he said, sir, how can we do it? So then I just told him, sir, we are doing kidney transplant. So why can't we do a lung transplant? Because ultimately, how we have learned about immunology is when I was at Yashoda Hospital, when we were doing the lung transplant program, we were not having an immunologist with us. And we were discussing with our nephrologist about, once we get the PRA level, how to go about it, how to go for the next Luminex testing and all these things. And slowly, maybe we were understanding very little, but we were getting a little bit of idea about it. So I sincerely feel that this whatever lung transplant or even heart transplant and even the liver transplant, it should not be restricted only for a few very high institutions. And when we can spread this knowledge across everyone, even across the MBBS students should be aware of it. And in that way, what can happen is it can grow in all the institutes all over the country. So in that way, we would, as being, even though we are in the private organization, we having the opportunity to learn and also have gone abroad a few times and want to spread it to other, to the upcoming postgraduates and also the students. and hope that this small seminar which we are presenting will open up a lot of young minds who are here and get them interested towards this specialty. Thank you, sir.
Thank you, sir. Thanks for your wonderful message and for also appreciating our institute also, sir. In fact, we are the highest number of handling the bronchoscopies and thoracoscopies in the government sector in Andhra Pradesh, sir. And I don't know that the value of modular OT also till the fact you are impressing upon. And definitely we'll take your advice most positively with the help of our principal as well as vice principals are also, because they are also supporting a very big way to this department. And definitely we'll take the message forward and we'll do the best thing, sir. Thank you. Because this is the best hospital actually. This is a isolated and exclusive pulmonary specialty with infrastructure very good in manner. So definitely we'll think of these things, sir. Thank you. Thank you, sir.
Next, I would like to call upon Dr. M. Neeraja ma'am, Consultant HOD, Department of Transplant Immunology from Apollo Hospitals, Hyderabad, to share a few words with us.
A very good evening, everyone. First of all, I would like to thank Principal Sir, Vice Principal Sir, and the entire team of Government Chest Hospital for giving me the opportunity to present before you. As Dr. Naresh Sir said, we should enlighten the young minds to learn new fields of specialities, and you should increase the awareness among the present clinicians that transplant is a thing where you can save many lives. A person who is a cadaver, I have seen in the news, they are donating a lot of organs. Like one person in Hyderabad, he had saved 8 lives. So that's how the transplantation plays a role in saving lives of many. So I think I wish all the best to the Government Chest Hospital, and I hope that the lung transplant and the heart transplant is done in a big way in even in AP, and we should spread this message among all the young and the old clinicians also. And we should be aware of the new technologies, what is being developed each and every day. And the post-transplant and the pre-transplant workup is very, very important because transplant is a big thing, but managing the patient after the transplant is a very big issue. Because patients, we have seen, I'm a member of Transplant Authorization Committee of Apollo Hospitals. So when we take the interviews of the patient before the transplant, the patient will ask us questions. Madam, transplant aipotadi kada, tarvata we will be very safe, so we don't have to take so many medicines what we take now after the transplant. So we tell them, see, transplant is not a basic surgery. So you have to be aware of the post-transplant infections, the post-transplant rejections. So during the committee, when we authorize for a transplant, we ask them the questions, are you aware of the rejection or not? So the patients will ask us, Madam, rejection ante enti? So we tell them, ippudu meeku heart transplant chestaru or lung transplant chestaru, it doesn't mean that the body will accept that organ because it doesn't belong to you. It belongs to someone else, and the body will detect it as a foreign organ. So adi meeku match avvadaniki it will take a long time. So you be very strict under isolation and maintain all the protocols even after the post-transplant. Don't jump into parties and all gatherings after the transplant. Then they will ask us the questions, Madam, how long should we be in isolation? But transplant cheste use undi, Madam, why we should be in isolation even after the transplant? Then we have to again explain them that you will be under a lot of immunosuppressive drugs, and because of that you will be prone to a lot of viral infections or bacterial infections. So that will lead you to another way. So that all things we have to take under considerations when we go ahead with the transplant. Lot of counseling is needed for the patients before transplant and even after the transplant. So that is the only take-home message as an immunologist from me to you. Thank you so much.
Thank you, ma'am. Next, I would call upon Dr. BMS Pathuru sir, Professor, Department of Pulmonary Medicine, to share a few words with us.
Good evening you to all. Respected dignitaries on the dais, Principal Sir, Rajan Prasad Sir, and my colleague Naresh Sir, Superintendent Sir, Bhushan, and also our beloved Madam Souri Kumar also attended at this session. We are very pleased to say. The idea of doing this particular session is that I am known to Naresh sir for a decade, long time. See, as PG students are increasing more, we thought we put some insight into the lung transplant, organ transplantation. So therefore, I called him to give a talk. Immediately, he obliged in no resistance at all. And coming over here and giving talk, along with that, what he said was, no, what I will teach only the surgical aspects. I will also carry an immunologist who is well versed with us so that the students will be enlightened much. In the same fashion, he also took Dr. Madam Neeraja also here. And at the same time, we thought we have ample space. Say this, you wanted to see, sir, like this laminar flow theatre and KLM lighting, KLM, etc. Left idle without doing anything. Then I thought, sir, what is wrong in going for a thoracotomy, doing some surgeries here? He said, no, why you are asking me? You as well can go ahead with it. But Sankomlo postene తీర్థం అంటారు కదా సార్, అట్లా ఆయన యాక్సెప్ట్ చేసిన తర్వాత ఇప్పుడు నౌ little changes, some little changes, we as well want to go for a thoracotomy procedures regularly with the help of principal sir and other department from the, so that insight he put on to the mind, and from hereafter we want to work on that. So therefore with these words I thank Superintendent sir and other dignitaries. Thank you very much.
Thank you, sir. Now I'd like to call upon Dr. J.V. Praveen, sir, Associate Professor, Department of Pulmonary Medicine, to give a word of thanks to all the dignitaries.
Good evening, everyone. I, Dr. J.V. Praveen, feel very privileged to deliver vote of thanks on behalf of Department of Pulmonary Medicine. I would like to thank our principal sir, Muchraj sir, our vice principal sir, and other dignitaries also. And I would like to thank our first speaker, madam, who has already delivered her lecture, Dr. M. Neeraja madam, who is a PhD and consultant and head of the Department of Transplant Immunology and in Apollo Hospital, Jubilee Hills, Hyderabad, and who has already enlightened us and gave us a lot of knowledge about the HLA in organ transplantation. I would also like to thank our special speaker, today's special speaker, Dr. P.V. Naresh, who is a senior consultant in CTVS, Apollo Hospital, Jubilee Hills, Hyderabad, and he would be enlightening us on ECMO, physiology indications, heart lung transplant, and its present status in India. I also like to thank Dr. Sunil Kumar sir for our superintendent sir for making all these things happen. I also thank Dr. B.M.S. Pathrudi sir and also Dr. Bhushan Rao sir, head of the Department of Pulmonary Medicine. And I also like to thank our third speaker. That is, the third speaker will be Dr. Bhattu Chaitanya, who is a DNB pulmonology, who did her DTCD in our government hospital for chest and communicable disease. Later on, she went on to do DNB in pulmonology, and now working as fellowship in transplant pulmonology at Toronto General Hospital in Canada. And she is also a consultant, she worked as a consultant pulmonologist in Apollo Hospital, Jubilee Hills, Hyderabad. And I also like to thank Dr. Suri Kumari madam, who is head of the Department of Pulmonary Medicine in Kakinada. And I thank all the faculty members and postgraduates present here for coming to this CME. Thank you very much.
carry on.
Now let us continue the session. I would like to call Dr. BMS Pathuru sir to share overview about lung transplantation.
Okay, I am not here to share the overview of lung transplantation. That will take care by Dr. Naresh. What I want to say is, what I am now is today is because of contribution from the CT surgeon, isn't it? See, the moment I completed anesthesia in 2000, I joined in Apollo. At that time, most of the heart surgeries means coronaries. Coronaries done on bypass. Majority of the times, coronaries at that time was done by the bypass. So the music that we are going to face is post-operatively because patient is on pump. There are so many insults from the pump, not from the patient. So the whole night we have music, isn't it? So I thought, no, why these guys are doing like this? Patients are been baffling to get on day 3, day 4, day 5 also. They could not recover as much what they expected. At that time, this was the talk. Sir, Venkateswara garu sir kuda vachara. Welcome, sir. Sir also started his career in Apollo since, sir, first batch, 1990 to 2000, so at that time. So at that time, so this was happened between 2000 and 2004. In 2004 December, Dr. Naresh entered the Apollo hospital. Then, as usual, no, we thought of going for CABG means pump, and CABG, doing CABG with always, so almost there are about 500 Schwann gauge catheter I used to keep. So between 2000 and 2004, every patient intubation means you have to put Schwann gauge, isn't it? To keep the wedge pressure, to keep the RA, to keep the LA, etc., etc. And also another colleague by name Ramohan. See, that's what why I took Mike is the fact that see how it has evolved, isn't it? So at that time, Ramohan also, Dr. Ramohan is anesthetist, cardiac anesthetist. He also came. How he came? Because Sar and Ramohan worked together. So when Sar came in, he took Ramohan also into consideration into the team. So at that time, the paradigm shift, what happened was, we start doing beating heart. For the first time in Vizag, Apollo started CABG undoubtedly, but the outcome of the patient recovery was hugely increased. When somebody is doing bypassing pump and doing on beating heart. So for doing beating heart surgeries, coronaries, anesthetist is key role. So it was the Ramohan, sir, stand up please. It was the Ramohan who insisted, no, sir, we have to do in beating heart. Then we keep on doing that, succeed so many cases, coronaries. And in 2006, Rajshekar Reddy, before Rajshekar Reddy became chief minister in 2004 it seems, 2004, from 2004 to 2006, congenital, so many congenital cardiac surgeries came in, before Arugshri. So there are about 400 congenital cases, free of cost they had done. It was a huge boost for the city. Most of the cardiologists, they used to refer, even for complex congenital also, he never hesitated to do that. He never hesitated to do because he has a good anesthetist and also a team. Fortunately, I am in the team, isn't it? So therefore, it went on like that, and in 2000, between 2008 and 9, he doesn't stop there. He go on to take minimally invasive cardiac surgeries. Instead of doing labor sternotomy, simple thoracotomy, a single space, doing some grafts, that also he did. And what happened at that time, I am also wavering whether to continue this anesthesia or go to something else. I always keep wavering and doesn't show much interest on any of the aspect. Then he started to pull me to take a cardiac transplantation also. So we went to Cherian's Hospital. Cherian's Hospital, where cardiac surgeries, you know, he is a famous congenital cardiac surgeon, world famous. So at that time, the lung transplantations are also going on there. He joined, he took me away. So I worked there for 4 months somewhere. 4 months. Hardly I could attend three lung transplants, that too donor aspect we gone there. Only we retrieved one case. Of course, we could not able to do that before keeping patient on ECMO itself, on pump itself, that guy is gone. So in that way, he has so much of passion on keeping me into that side, anesthesia side. But, but luck or bad luck, I get out of that and joined again as a assistant professor here in 13. I am continued. Still he is doing there. Now the point is, always if you have any doubt, say don't get away with the cardiologist opinion. Always take a consult from the cardiac surgeon. So whenever you got an angiogram of your relatives or within the family members, always consult a surgeon also. Cardiologist says something, but you also take the opinion from the surgeon. So that's what I want to say. Whatever the knowledge I got, he himself has introduced, we have fishman, this man, that man, we are reading. But surgical aspect, what the books you have to read, at that time itself, in 2006 itself, he introduced it. So that is why some extra corner, what I gained is gained from the anesthesia, cardiac anesthesia, chest and transplant aspect. So cumulative of all these things is today's pathology. Nothing more than that. So I thank Naresh sir and Ramohan, very good anesthetist. So I am very happy that we all four together. That's what the introduction I want to give. Apart from that, senior pulmonologist of the city, Venkateswara also used to be there with the team. He used to take all cases of Dr. Naresh. So yeah, I'm happy, sir, you came here. With this, I want to continue the talk of Dr. Naresh.
Thank you, Pathulu, for such kind words. I will just continue with our so lung transplant being a topic, so without knowing about ECMO, there is no point going towards lung transplant without knowing about ECMO. So just I will start. So today I just wanted to, because most of our being students, and they must have seen ECMO, and most of our clinicians, at least before COVID, very few clinicians, even pulmonologists also, were not having very much knowledge about ECMO. Frankly speaking, when we finished our cardiac surgery in 2000, even we were not exposed to ECMO machines. It was hardly present in only 1 or 2 hospitals across the country. And it used to be very catastrophic event, like patient is in very bad shape, like post cardiac surgery, we are not able to wean him off the heart-lung machine. Then we used to put the patient on ECMO. Gradually, the machine or the ECMO machine has got evolved into different, it used to be first a roller pump, then it has become a centrifugal pump. Going into the technical details, I just don't want to do now, because it is a very complex thing. I will just tell you about the physiology of it. Physiology and a few of indications. So next slide, please. Next slide. I know changes. This is for me. Acha, where is the, yeah, yeah, I got it. Okay. So, what is ECMO? ECMO is it's a extracorporeal circulation with membrane oxygenation. So that is the full form of ECMO. And what happens, as most of you know, that we put ECMO whenever the conventional treatments are not working. Like suppose we have to treat a cardiac arrest, or suppose a cardiac failure, acute cardiac failure, anything. Like we first suppose a patient comes with an acute myocardial infarction and very severe myocardial infarction, anterior and global with global hypokinesia. Then what they do in the ICCU is they put him on inotropes and then give him the blood thinners like heparin and all, but the myocardium is totally damaged. So what we do is earlier we were not doing anything. We had to just put him on a ventilator and just wait for him to die. Now we have this machine, ECMO machine, where it can be installed into a patient. So cardiac arrest or circulatory failure, whatever we can say, is one indication. The next indication of late, I think with more and more acute respiratory illnesses or even chronic respiratory illnesses, is for respiratory failure also, which are not responding, like we have seen during COVID time or even before COVID when there was the H1N1 infections, where we had, at that time mostly, it was the time when ECMO we also got exposure to ECMO. So the basic physiology is, in an ECMO, when we put it onto a patient, whoever is sick, he has dual circulation. So you have to understand that. If you understand that, why dual circulation is, because his own circulation, his heart is pumping and the blood is circulating inside the body. And what we are doing is either from the venous side or from the arterial side, which we call veno-venous ECMO, and the other is the veno-arterial ECMO. So in the veno-venous ECMO, there is a dual circulation, there the extra circulation or extra blood is pumped onto the venous side of the heart. And in the veno-arterial ECMO, extra blood is taken out, whatever is taken out from the body, it is oxygenated and pumped into the arterial side of the heart. So its indications become different. That I'll be slowly coming down, then we'll come to know. So first I would like to tell you about the veno-venous ECMO. So oxygenated blood from the ECMO. So once what we do is we put a cannula inside the vein. So how we put the cannula is, we put it into the femoral vein just like how you put a venous anesthetists, they put a venous line by putting a guide wire, and over that we thread a cannula, and that cannula takes out all the blood and it comes to the machine, which is the oxygenator is there, and then the mixes, it is purified and again it is taken back into the vein. So this situation is used especially when we have respiratory failure. Respiratory failure where we are all the other conventional methods, like we had tried to put him on a ventilator, and even now I think during COVID time you must have seen we tried to put him on a prone position to increase his recruitment of the lung. Everything has failed, and then we have to go to this situation. So what happens is the deoxygenated blood is coming out from the right atrium and is again pumped into the right atrium. The purpose of it is we are giving a little bit of oxygenation of the blood, and it goes through the pulmonary circulation. So in the pulmonary circulation, what is happening is the blood is just passing through it, because the lungs are not working now, because like they have become, due to pneumonia or due to whatever the fibrosis, their lungs are not working, so they are just passing through the pulmonary circulation and coming to the systemic circulation. So what happens is, as the saturation improves, if the lung, so by doing this, we are giving a rest to the lung. So the lung is inflamed, acutely inflamed. So we want the lung to be rested and give it some time to recover. So as the saturation starts improving, we know that the lung is improving. So what happens is, how this lung improves? What happens is, by giving this little bit of oxygenated blood, there is some amount of pulmonary vasodilation which is happening. So this pulmonary vasodilation will decrease the pulmonary artery pressure. Normally what happens, if suppose we were not doing the ECMO, the patient, there is an increased resistance in the lungs, the pulmonary arteries, the blood is not able to flow through the pulmonary arteries are constricted, and what happens, the right ventricle starts failing. So when the right ventricle starts failing, it starts becoming enlarged, RV pressure goes up. When the RV pressure goes up, it pushes the septum towards the left ventricle. So the next thing what happens is, the left ventricle is not able to pump. So we are trying to reverse this process. So by giving a little bit of oxygenation, the oxygenated blood is going to the pulmonary circulation, vasodilation, and then it improves the left ventricular function and decreases the pulmonary inflammation, and then the healing process starts. So you have to understand this thing, which is especially for the respiratory physicians, that what is the basic way in which a veno-venous ECMO works. You should be very well also you should know that, suppose if a patient is having very severe right ventricular hypertrophy or right ventricular dysfunction, sometimes the veno-venous ECMO may not work. Why? Because we are adding a double circulation into the right side. Understand? So what happens is, suddenly there could be a right ventricular failure, right ventricular stunning, and patient's hemodynamics can go down. So if we are finding that situation, so usually what happens is, in that type of situation, the patient is also in shock because of the hemodynamic right ventricular failure. So we have to change to a veno-arterial ECMO when we know that the hemodynamics is compromised. So we can do a veno-venous ECMO only if the most of the hemodynamics are maintained, and he is just on a ventilator but is not getting oxygenated. Rest of the blood pressures are good, his CVP is good, and his PO2s are low, like 40 or 50. So this is a very important aspect of the veno-venous ECMO. And one thing you have to understand is, veno-venous ECMO doesn't improve the hemodynamics of the patient. It is not, because only hemodynamics will improve if suppose a patient is in shock due to respiratory failure or any other thing, then we have the veno-arterial ECMO. So the veno-arterial ECMO is, we take out blood or we drain the blood from the venous system, either by a single cannula or two cannula, depending on the situation. And I will just show you a short video, you can understand that. And then we return the blood after oxygenation back into the femoral artery. So that is a very commonly technique which we do in case of adult patients. In case of pediatric patients, it is very difficult to get a good femoral artery because they are very small, and we can damage the femoral artery. So we do either through the carotid artery, return the blood through the carotid artery, or through the aorta. For returning the blood to the aorta, we may have to do a sternotomy, but sometimes it is not necessary. We do a small sternotomy or a small thoracotomy, and we can cannulate the aorta and we can return the blood. So this is a dual arterial circulation. What happens is, why dual arterial circulation? We are taking out the venous blood, oxygenating, sending back into the aorta. At the same time, you should understand that the heart is also pumping. So when the heart is pumping, its own blood, which is less oxygenated, understand? Because the heart is we are not keeping the lungs ventilating, or the lungs is not functioning at this time. So the oxygenated blood, the blood which comes into the heart, will be less oxygenated. So when these two circulations mix in the aorta, then there is a clash. What happens is, the deoxygenated blood from the heart is coming up to the aorta, and the oxygenated blood is coming from the femoral artery up. So When these two mix, then we get something called a differential of oxygenation. So what happens in a femoral artery ECMO is the lower half, left upper half, and the left upper half will get oxygenated blood, but the brain and the right upper half will get deoxygenated blood because of the pumping of the heart. Now, you can say that, okay, we can stop that by, completely allowing the heart not to pump. But that is not advisable, because as far as ECMO is concerned, what we do in a open heart surgery when we are doing, we completely empty the heart and we can even stop the heart at that time. But in an ECMO situation, it is not possible. We can do only like 80% of the cardiac output. If you try to do complete, that means 100% of the cardiac output, then anyone can tell me what can happen? No, it can collapse. There is another situation. What will happen is I will be slowly coming into it. So now what happens when we try to know what happens? What are the effects? How the circulation is getting help because of a veno-arterial ECMO. First thing you have to understand is, because we are draining out the venous blood, the preload of the heart is taken care. So we are decreasing the preload of the heart. Okay. So when the preload of the heart is taken, it gives some rest to the heart. But what happens is, and there is a decreased forward flow, and also coronary perfusion is getting decreased because the heart is pumping less amount of blood and the coronary perfusion is getting affected. So whatever is the deoxygenated blood, relatively deoxygenated, is going into the coronary perfusion. So what happens is the heart is relatively ischemic in this situation. I don't say it is ischemic, relatively ischemic, because it is getting less oxygenated blood. So with femoral artery ECMO, when we are pumping the blood in a reverse direction, what happens is it is going at a flow. The ECMO runs at a flow of 4 liters or 3 liters. We are increasing the afterload. So when we are increasing the afterload, what happens is the heart has to pump against a higher pressure. So the heart will start failing. Understand? And moreover, what happens is, then it can lead to overdistension of the left ventricle. Why? Because we are not taking care of the venous return which is coming into the heart cavity through the coronary sinus and through the Sebacean veins. They are not being taken care. So it leads to distension of the heart. So we have to be very careful, because everyone it appears to be very simple that the circulation is going on and there is some damage to the heart. We just put a ECMO and it is taken care. So it is not as simple as that. So what we have to do in this situation is we should think of venting the left ventricle. So when we come to this situation, what we have to do is we then have to do another procedure. Sometimes there are catheters available where we can, through the, using our, like in cath lab, we can, through the septum, and we can go into the left ventricle and the blood will be sucked out and then put it, and it comes to the ECMO. So these are all things which have to be considered. And what happens for a right ventricle when we are doing the ECMO, when veno-arterial ECMO? It decreases the preload and it also increases the afterload. Why it increases the afterload? Because the lung is not functioning, because the pulmonary circulation is taken away. When you are taking out the venous blood and putting into the arterial blood, the pulmonary circulation is not going on. So when the pulmonary circulation is not going on, your lung is collapsed. So it gets constricted. So the right ventricle can fail. So all these things have to be balanced whenever we are putting an ECMO. We have to see how much of the patient, that is why whenever we put the patient on ECMO, we put some little bit of ventilation, and always we can't put it on 90% or 100% ECMO. There should be a ratio which has to be maintained. So these are the way in which the ECMO as a pump, how it functions and how it affects the physiology. One thing I forgot to tell you is what happens in the cerebral circulation. Because of, whenever we do a femoral arterial ECMO, what happens is, I told you, the oxygenated blood goes only up to a part of the aorta. It just doesn't reach up to the cerebral circulation. So maybe a little bit of cerebral circulation may be receiving oxygenated blood, but mainly through the carotids and the brachiocephalic, you will get less oxygenated blood going to the brain. So there is some amount of compromise to the brain circulation, and also this less oxygenated blood will be going to the heart also. So there is a situation where heart also gets less oxygenated blood. So now the next thing we have to understand is about the ECMO machine, the machine which contains a pump and then it contains an oxygenator. The blood is taken out from the body and it runs through an oxygenator. Now, this oxygenator, how does the gas exchange occur? So now there are a lot of the laws according to which fluid and gas exchange, which you must have studied during your intermediate, 11th, 12th class. So anywhere the passing of a gas, especially, is depending on the partial pressures. Okay, the amount of pressure which is present. So in a lung, the exchange is in a different way, but in an ECMO, the exchange is it occurs in a counter current mechanism. So what we do is we pump the gas, whichever oxygen, into the thin membranes. There will be thin membranes through which the blood will be passing. So in a counter current mechanism, the blood takes over that oxygen, because whatever the blood which is passing is having less oxygen content, and we give the gas whatever is required. We give it as a particular FID. We don't give always 100%. Whatever is required, we keep giving as a mixture, and then that will be exchanged into the blood, and whatever the blood comes out will be the arterial blood. So all these calculations, when you go into, once you are practically getting into ECMO, like if you are putting ECMO, then you will be all understanding this. So one basic thing you have to understand is the oxygen which is carried in the blood, mostly it is through hemoglobin, and the dissolved portion is very less, and carbon dioxide dissolves very well in the blood because it is more soluble, but oxygen is not so soluble. So going into that, 97% of the blood of oxygen is in hemoglobin. So if you go by the calculation, it is like 1.34 ml per gram. Sir, screen is wrong. Acha, oh sorry. I have to do that. Now I will just show you a small video of one cannula, like how we do a veno-venous ECMO. You can see that this is a cannula where we just put it into the jugular vein, and it has two channels. One channel will take the blood away from the heart, and another channel will just pump it into the heart. This is actually a very sophisticated cannula and is not freely available, but still I just wanted to show you to understand the physiology mechanism of it. Now you can see one of the port hole is inside the IVC, and the other hole will be in the superior vena cava. And whatever blood is going and then coming back into the right atrium. So exactly at the position of the tricuspid valve, so that there is no mixing of both the channels. Understand? So this is what I thought the slides were going, so sorry for that. So this is what I have been explaining, the effects of veno-arterial ECMO, the heart, how it decreases, it gives rest to the heart and decreases the native cardiac output. So it gives less forward flow, and also coronary perfusion is decreased. So depending on, so this is how no, the gas exchange happens. So a gas exchange, this is all basically physics, which we, if we keep reading, whenever we read the chapters on ECMO, then we can actually understand that how a ECMO exchange of gas happens. So the basic thing you have to understand is oxygen gas exchange. So you can see that lung, in a lung we can see how the oxygen is exchanged. 97% is through the hemoglobin and 3% is dissolved. So when in an ECMO oxygenator, the blood and gas pass through something called a countercurrent mechanism. So what happens is, as we increase the sweep gas, we call sweep gas is the gas which is passing through the ECMO oxygenator. Understand? And depends on the membrane type. There are different types of membranes. So better diffusibility membranes will give better oxygenation. Then the membrane surface area. So these are all the factors which affect the transfer of gas from oxygen to pass the gas into the liquid phase. And also the hematocrit of the blood which is passing. And then I will come to a calculation which I will just show you in a short while, where you will come to know how it is going to get affected. So as far as carbon dioxide is concerned, it is more and more in a dissolvable phase. So only 70% is transported as bicarbonate, and with combination of hemoglobin only 23%. So you can see that oxygen is affected by the hemoglobin concentration, but carbon dioxide transfer is not affected by the hemoglobin concentration. So now this is what I would like to explain of mixing of the blood due to the, just before that I think I will just show you one. Yeah, I just wanted to show you this one picture where how the the concentration, I think I'll go back here. It will come. So now, ultimately, the purpose of oxygenation of the blood will depend on the mixing. So in the mixing of the blood, what happens is, whenever we have a veno-venous ECMO, you can see the mixing is at the right atrium level. Whatever we are using, if we are using a 2 cannula to remove the vein, and again we are bringing the blood into the right atrium so that it can directly go into the right ventricle. So SpO2 will be the low all throughout the body, because whatever is going into the right atrium is just going into the lungs, and where the lungs are non-functional, and then it is pumped in by the ventricle throughout the body. So the PO2s will be low. If the PO2s keep improving, so what does it mean? It means that the lungs are improving. With the same ECMO settings, if the PO2s are slowly improving, then the lungs are improving. So that is how we know that the patient is improving. Sometimes we may not find any X-ray improvement or not, but gradually over the time we can see the improvement in the X-rays. So when we have a veno-arterial ECMO, the mixing is in the artery. So there is a high PO2 and SpO2 levels, and it will not be uniform, like I explained to you, because the upper half of the body will be having less PO2 and lower half will be having the higher PO2. So, and also it depends on where we put the cannula. Sometimes if we put in the carotid, we can have a equal PO2 levels. So that is why what we do is, usually in children, when we put, for small children, we put it in the carotid because femoral artery is not so much accessible. But in adults and all, it is not so easy to put in the carotid because it affects their cerebral circulation, and sometimes they may be having some carotid, if we block one of the carotid, it can lead to stroke and all. So mostly what we do is, we put it in the femoral artery. Now what happens? How do we change? Now suppose I have told you that there is a differential. The upper half of the body is getting less oxygenated blood, and lower half is getting more oxygenated blood. So in such situation, what what we have to do is we have to adjust the levels of the ECMO, or we have to change the cannula, because if it is causing too much of oxygenation difference, we may have to change the cannula, or we have to put it into the aorta, or if possible into the carotid artery. So now what happens? Now after the oxygenation is done, next thing is what is happening at the tissue level. Because our purpose of oxygenation is not only for the circulation. Now whatever patients we put ECMO for are in very bad condition, like they are having severe vasoconstriction, severe sepsis, or severe lung failure. So now our basic purpose is we have to see how the oxygen is delivered at the tissue, so that we get improvement in the circulation or in the patient. So coming to the oxygen consumption, which is called as VO2. Okay, that is the terminology for oxygen consumption, and oxygen delivered is called DO2. So we should be knowing about these two terms. DO2 is the delivered oxygen, and VO2 is the oxygen consumption. So this oxygen consumption keeps increases due to muscular activity, infection, hyperthermia. So if effectively ECMO has to run, we have to keep all these things under control. So how do we keep these under control? Muscular activity. So what do we do is we paralyze the patient. We don't allow him to get into too much of muscular activity or getting irritable and all. And then infection, we have to keep proper antibiotics to get the infection controlled. He gets fever, you have to control the fever by getting his fever down. Then, so that is why oxygen consumption gets decreased by rest, paralysis, and hypothermia. So now, what is the oxygen? This is the content of oxygen in the blood, arterial blood. Okay, you should understand this also. Seeing that it's a dissolved oxygen plus hemoglobin oxygen. So there is the calculation which we see as per the PO2, and whatever is the dissolved oxygen, that is per ml, and then hemoglobin level. When we calculate that, we get it around 20.5. Okay. Now the next thing is we calculate the venous oxygen content. We have to know the content. Only PO2 or saturation is not sufficient. So when we calculate, it comes around 15.2. So the venous saturation, so the difference is roughly around arteriovenous difference. That the arterial content minus the venous content is roughly around 5.35. So this is the combined picture which shows you how the oxygen delivery is affected. You can see the delivery of the oxygen, which we call the DO2, is the delivered oxygen at the tissue. It depends on the cardiac output and the content of the oxygen. So the content of oxygen in the blood. So the content can be calculated by this formula, and cardiac output is heart rate and stroke volume. So now heart rate and stroke volume are directly affected by the preload, the cardiac function, and the afterload. So what our ECMO does is, it takes care of the preload, it takes care of the cardiac function, and also the afterload. And then you have better delivery of oxygen. So now one important thing, how hemoglobin is very important. So this I think everyone knows of, they must have read in physiology. Like we will be thinking, like if we want to increase the PO2 of a patient, you can see like at a hemoglobin of 10, okay, and a saturation of around 50, you can see how much it is at a saturation, the content of the oxygen content. Now you increase the hemoglobin, the content increases even at low saturation. So the hemoglobin level is very important. That message I want to just convey it to you, that if you suppose keep hemoglobin at 10 and you keep running the ECMO, it doesn't mean that you are delivering the sufficient oxygen to the tissues. Very important is, because oxygen is mainly carried by hemoglobin, you have to see to it that Because when we are doing a ECMO, there is some amount of dilution because it is a second circulation going on. We keep adding what many of the perfusionists also we see, they don't understand this physiology. What they do is whenever the flows are not meeting, they will just connect a IV fluid and they will run fluid into the thing. Then what happens is by the morning the patient is totally cold and he's severe acidosis. Why severe acidosis? Because his tissue is getting into anaerobic metabolism. So only we have to understand the physiology. And I didn't want to get into more of all the technical things, because if you understand the physiology, technical things you just read in the book, you can understand, because it is just running the pump. And most of our perfusionists who are there, who are doing, who are not experienced with ECMO, they even don't know much of, that hemoglobin is such an important thing. You give blood when the patient is, having this problem with oxygenation, then it will improve. If you give only IV fluid, what will he's getting? He will go into more low hemoglobin. And as he goes into more hemoglobin, his oxygen content will go down. So that is the main important thing which we should understand, that whenever a oxygen to be delivered at the tissue in a normal person, we have content of oxygen is roughly around 5 times what it is to be delivered at the tissue. And when it gets to below 1:2, then it becomes anaerobic metabolism. And once you go into anaerobic metabolism, then it is a vicious cycle. The ECMO will be running, but you will not be able to give any tissue healing or any benefit to the patient. So to know this, the mixed venous blood saturation is a very important thing, and that gives you, because that indicates the mixed venous saturation is the difference between the arterial and the venous oxygen content. So that gives us an idea of how much of the tissue is taking the oxygen. If suppose our mixed venous saturation is very high, that means the tissue is not taking any oxygen. So you are not serving the purpose of putting the ECMO. Ultimately, you have to put the ECMO so that the tissue has to take oxygen and the tissue circulation has to improve. And tissue means it includes all. It includes the kidneys, it includes your liver, it includes your brain and everything. So this is the very important. So mixed venous saturation. And oxygen delivery can be improved by increasing the oxygen saturation, increasing the PO2, so increasing the cardiac output, and increasing the hemoglobin levels. So this is the important message which I wanted to tell you. And then, so this is how we improve, either by improving the native plus ECMO cardiac output. Suppose the heart function is good, we can always improve the heart function along with ECMO by putting some inotropes and removing the CO2 by the sweep gas. So removal of carbon dioxide is also important. So as far as the gaseous exchange is concerned, factors affecting the gaseous exchange are native cardiac output, native pulmonary function is also important, ventilatory settings, with its FiO2, ECMO sweep gas, HB levels, and site of mixing and of ECMO and the native circulation, which I have been telling you right from the beginning. So now we must have got a little bit, I don't know how much you must have got, because I may also not have been able to convey effectively, but a little bit whatever you can, I think you should go home back and read these books. Especially there is a red book which is called about ECMO, which is a very important book when in pulmonology, if you keep reading, because more and more we are seeing pulmonologists are seeing their patients in their ICU, or at least 1 or 2 patients are having ECMO. So they should be also understanding about the ECMO physiology and all. Now we have the basic 2 types, and we make a small combinations. Like suppose we have the basic VV ECMO and VA ECMO. Then we have one called VAV ECMO. So why it is VAV ECMO is, now suppose we get we drain the blood from the vein and then return into the artery. Now what happens is, we have again, like I told you, the differentiation of the differential circulation which has happened, where there is deoxygenated blood, going into the into the brain and the upper half of the body. Then we can always put another cannula into the vein. So what we are doing is we are little more oxygenating the venous blood. So whatever blood is going into the heart can again be little more oxygenated. Understand? Then there is a veno-venous ECMO, two venous drainage. Now if we put a cannula and we see that the drainage is not sufficient, we are not able to maintain the flow, then we add another venous cannula to get better drainage. So ultimately we have to drain the vein properly so that we can maintain the flows. Then this is also same, which a variation of the VV ECMO. Like suppose if you are not getting better drainage, then we can put another drainage cannula and connect it so that it can return to the back to the vein. Then there are other combinations which I think I'll just mention to you for removal of carbon dioxide, where we can remove the carbon dioxide using the ECMO. It is just either through arteriovenous carbon dioxide removal, we just run it through the ECMO machine, through the filter. One side it is connected to the artery and another side to the vein, and we run the oxygen to it so that the carbon dioxide is getting removed. So these all, I don't want to get into much details, that will become too elaborate. So just coming to the indications, so you have to very clearly understand that whenever we have a VA ECMO, mostly it is circulatory failure due to whatever reason. Either it can be prolonged cardiac surgery where we are not able to come off bypass, like suppose if you have taken an acute myocardial infarction with a massive septal rupture where we have whole myocardium is necrosed and we are not able to come off bypass, then we give rest. It is like continuing the bypass for some more time so that the heart can recover. Then in some pediatric patients like obstructed TAPVC and all, we use this, but not every time. Cardiogenic shock due to septic shock, sometimes due to respiratory failure, myocarditis, acute myocardial MI, acute pulmonary embolism, severe valvular lesions, refractory arrhythmias. These all reasons due to cardiogenic shock. Then there is a concept called eCPR. So this is slowly coming up in different hospitals, is ECMO CPR. Now a patient has come to you in the casualty with acute myocardial infarction and has just arrested in front of you. And you have done your protocol of CPR and is not reviving. Young patient. So any patient who arrests, mostly it is due to a MI. And what you do is, if you have a eCPR protocol, what they do is the emergency medicine guy, he activates the protocol within 20 minutes so that by the time the perfusionist and the surgeon and all come, it will take some time. And then they prepare a ECMO and just put a femoral cannula and a femoral vein and femoral cannula and start the ECMO. So now you have taken care of the circulation, the brain circulation, everything taken care. Then you can see what can be done to him. You take him to the cath lab and you do an angiogram, and if you see a left main obstruction, you either open up the left main, or if it is a main artery, open up, or if you feel that he is to go for surgery, we can take him for surgery. We have seen in eCPR, 40% of the patients can be survived who have arrested and who have put him on ECMO. Then the other most important thing is whenever we have patients who are heart failure and we bridge them to transplant or LVAD. So this is just like a chronic thing, like patient has been for a long time waiting for transplant and he has suddenly collapsed in the hospital or he's become very bad hemodynamically, we can put him on an ECMO and then bridge him to transplant. And also patients who are like acute, even lung patients who are like ILD patients, or even who are like on oxygen and all, we keep coming to the hospital for acute exacerbations. Sometimes they get onto ECMO. So there are also indications for putting a patient on ECMO. And usually they are put on, if they are hemodynamically stable, we put them on a VV ECMO. If they are very bad and they are in severe vasoconstriction and shock, we go for a veno arterial ECMO. It is VA, always VA. VV doesn't take care of hemodynamics. It only takes care of oxygenation. That is the very basic thing everyone has to understand. VV only takes care of oxygen. If you are all doubtful that his hemodynamics are going to get affected or he's like in borderline, like sometimes we see, patients we have seen during COVID time that usually during our COVID time we had referrals to the last moment. When patient is getting sick, they have tried prone, they have tried supine, everything, and he is not recovering. At that last moment, what they is, they call us for ECMO. And we are also in a confusion whether to put a VV ECMO or a VA ECMO. And when we put a VV ECMO, suddenly because of that right ventricular distension and all, he deteriorates. Then we have to again convert it into a VA ECMO. So we have to make that, due to our experience, we make that calculation. Okay, this fellow will need an ECMO for a long time. And we also see that he doesn't develop the north-south syndrome we call because of that differential circulation happening, oxygenated, deoxygenated blood. What we do is we sometimes go for a central ECMO. We put a small right thoracotomy incision and we get the aorta there. We just put a cannula into the aorta and one cannula into the femoral vein, and then that takes care of the ECMO. Yeah, once his circulation is restored and you know that he is all peripheral, his oxygenation is good, mixed venous oxygenation and all, we know that things are better off, we have to convert it into VV ECMO. Because what happens is when you continuing veno-arterial ECMO, his lung will not improve. Why? Because you are taking off the pulmonary circulation. If you are taking off the pulmonary circulation, the pulmonary it tends to get into fibrosis. So you have to keep the pulmonary circulation on so that the alveoli will keep open, or whatever your antibiotics which are giving has to reach the lung also. For that. And circulation is more important, and otherwise it will become constricted and slowly it will become fibrosis. Yeah, you have to convert. What we do is we take out that cannula and then put it into the right atrium. Or I showed you one single cannula. Sometimes what they do is we put that single cannula and take out this both cannula. Because if he has to be on a long time, if we keep a femoral cannula, it is difficult to mobilize the patient. When a patient is on a VV ECMO, we have seen, I think, even our singer Balasubramaniam, he was there when he got ECMO. He was there on a VV ECMO and he was doing exercises, sitting on the bed, doing all the exercises, but he developed some complication due to the CV or something, so that he couldn't make it. But you can keep him for, even we have kept in our hospital for even 3 months on VV ECMO. But once they reach to a stage where you know that they are not coming out of ECMO, then we have lung transplantation. That is the only thing which is. So as far as venous ECMO is concerned, I think it is only pulmonary respiratory failure. And if respiratory failure compromised with the leading to cardiogenic shock, you should go for a veno-arterial ECMO. So advantages of the venous ECMO, like you are asking, pulmonary flow is maintained, coronary perfusion is with oxygenated blood, and less neurological effects because we are not entering the arterial circulation. Another important aspect I forgot to mention is about femoral artery. When we put a femoral artery cannula for a long time, veno-arterial, we are going to affect the distal perfusion of the femoral of the leg. So we have to give a distal perfusion cannula. Otherwise, he will start developing thrombosis because of stasis of the circulation, because we are giving the cannula in the opposite direction. So there is no perfusion into the limb. So he will start developing, and you have to do embolectomy and muscle necrosis and all. No, but there is no circulation. The cannula is completely into the lumen of the femoral artery. So it is totally obstructing. So you are not giving any circulation down. So naturally, even if it is ACT is maintained, that blood has to clot. No, if the ACT is 600 or 700 seconds, after that it will clot. So it's not going to stay forever. This thing. So with this, I'd like to conclude my talk, and I think we will go for the talk on Dr. Chaitanya. She will be elaborating about how to work up and go for the lung transplant mission. So this will be a recorded talk. I think we can all listen.
Thank you, sir, for your detailed and simplified explanation on ECMO. Next, we'll be having a recorded session about the referral listing and post-transplantation survival in lung transplantation patients by Dr. B. Chaitanya ma'am.
Good evening, everyone. I'm Dr. Bhattu Chaitanya. I'm a consultant transplant and interventional pulmonologist at Apollo Hospital, Hyderabad. Currently, I'm doing my clinical fellowship in lung transplantation at Toronto General Hospital, Canada. I would first of all thank Dr. Naresh sir and Dr. Pathudu sir for inviting me to present about lung transplantation. I'm really honored to have the opportunity to address such a distinguished audience. I really miss being there in person, as Chest Hospital is my parent institute, which taught me pulmonology. I'm a proud alumni of Chest Hospital, Vizag, and I had a privilege to learn from the legends of pulmonology. With this brief introduction, I think I'll just go on with the topic of today, like who is a candidate for lung transplantation in 2023. So every year, as years pass by, there are a lot of developments in pulmonology. So like we have seen 10 years back, there was nothing much intervention in interventional pulmonology, but now there are a lot of improvements. So the same in lung transplantation decade back, there was almost literally few guidelines or one or two papers on lung transplantation, but a lot has changed now. So now we'll just have a brief on who is a candidate for lung transplantation in 2023. My presentation will go through the following objectives. Like we for the first few slides will be on a general ethical and center-specific consideration in patient selection. And then I'll discuss few slides on contraindications of the lung transplantation and risk factors for poor patient outcome, followed by the disease-specific indications for transplant referral and listing, and then a comprehensive assessment of the transplant candidacy after we receive patients for the lung transplantation, and how do we manage patients on the waiting list. So we'll just go through all these objectives in my presentation. First, coming to general ethical and center-specific consideration in patient selection. Guidelines will be issued by the ISHLT body regarding the criteria for selection for lung transplantation. But apart from that, every institute should develop its own ethical principles in patient selection and organ allocation. So first one is utility, because lungs are a very scarce resource. We should utilize it to achieve the maximum benefit from the resource. So as we all know, one person's transplant may be another person's lost opportunity for transplant. So choose wisely which patient receives the lung and which patient shouldn't receive the lung. And we also have to have a thought process about equal consideration and opportunity for transplant for all those who benefits. So we should act regardless of societal rank and regardless of the race, gender, and socio-economic status. And the center should develop transparent guidelines for the candidate selection. Along with that, we should have a basic ethics, like we should not harm the patient by our intervention. And apart from these ethical considerations, there should be some center-specific considerations, as like the center should have some expertise of all the lung transplant team and resources in all the subspecialties of the lung transplantation. Apart from the specific clinics, there should be also a mechanical ECLS team, like ECMO team. And depending on the volume that the team does, they should accept the donors according to the, I can say, the experience they have. And also we should abide by the accreditation requirements and the government policies. And coming to the exact indications and contraindications for lung transplantation, I think this is one of the latest guideline from International Society for Heart and Lung Transplantation, which was published in 2021. which is a consensus document for the selection of the lung transplant candidates and is a must read for everyone who is interested in lung transplantation. First of all, before going to the introduction or the indications for lung transplantation, I just want to pop out on, I want to start on the contraindications of the lung transplantation. And while going through the different contraindications, I would like to show some examples where the regular contraindications there can be some exceptions for the regular contraindications. So the absolute contraindications are those conditions that are too high risk to allow successful outcomes and would carry risk of harm to the recipient. So when a recipient is having these following risk factors, then we should think of not transplanting these patients. The first and foremost is lack of patient acceptance of transplant. If the patient doesn't have any knowledge about the transplant, that means if the patient is not able to understand the consequences and the process of transplant, or if the patient is not willing to accept the transplant, we should definitely not transplant these patients, because it's a huge process. It involves a lot of patient education as well as the family education. So if we don't have a proper consent, better to avoid transplant. And other things are like malignancy, high risk of recurrence or death related to cancer. I'm going to stress on malignancy in the next slides, along with kidney dysfunction like EGFR less than 40 ml per minute, or acute coronary syndrome or MI within 30 days and stroke within 30 days, because these two are the conditions in which we usually use the anticoagulation or antiplatelets, which if the patient develops some ACS or stroke within 30 days and the patient is on anticoagulation, or if the patient is on antiplatelet therapy, then there are high chances of intraoperative bleeds. So better to avoid these patients within 30 days of the event. And patients with acute liver failure and acute renal failure with increasing creatinine or dialysis with low likelihood of recovery, these patients usually we avoid because there is another organ system which got involved and which doesn't have fair enough chances for stabilization before the transplant. And septic shock when the lungs are not the primary source of infection, or sometimes this can be an exception when the lung is the only source of infection. I'll deal with it in the coming slides. If there's any active extrapulmonary or disseminated infection, active Mycobacterium tuberculosis infection, predominantly drug resistant, HIV infection with detectable viral load, limited functional status with poor potential for post-transplant rehabilitation. This is very important, irrespective of the diagnosis, irrespective of the contraindication. If the patient is having a limited functional status, then the outcomes of transplant will be very poor. If the patient walks into the clinic or walks for the transplant, will go walking out of the transplant. But if the patient is bedridden, if he is not able to move around, if he is totally deconditioned, then there is no point in doing a transplant, because transplant process requires a lot of effort from the patient and outcomes really dependent on the patient physical conditioning. And if the patient is having a progressive cognitive impairment, or if the patient is non-adherent without evidence of much improvement, or if the patient still has an active substance abuse, like if a patient is still smoking or alcohol dependence or any drug abuse, or if the patient is having any severe uncontrolled condition expected to limit survival after the transplant. So if the patient is having the above issues, then it's definitely worthy not considering lung transplantation. As I have told you, there is the thought process on malignancy as a contraindication has been changing over the time. If there's a previous malignancy, then we have to assess for residual or metastatic disease. We have to consider new staging and risk assessment techniques at the time of assessment of the patient. And also we should work along with the oncology experts to assess risk of recurrence of the disease and what is the cancer-free survival of these patients. So there is a beautiful article in American Journal of Transplantation which gives us an overview of when to transplant after malignancy. In this slide, if we can see when to transplant after malignancy, there are 4 factors which will decide on when to transplant after malignancy. First of all, organ failure factors. In organ failure factors, there are like life-saving transplants and non-life-saving or life-prolonging transplants. And lung transplantation is a life-saving transplant. So, when there is a previous malignancy, if it is a life-saving transplant like a lung transplant, we can still consider doing a transplantation. And in case of other transplant like a heart transplant, if there are ventricular assist devices or dialysis or something, then options available, then we can just consider those options as such. In patient factors, the quality of life after the malignancy, and if the patient is having any modifiable risk factors like smoking or any other non-modifiable risk factor like genetic factors also should be taken into consideration. And cancer factors, like we should also know about the natural history of cancer recurrence, the time since cancer treatment was done, and what about the favorable stage or disease biology, and is there any effective available treatment for this patient? So all these has to be considered. And finally, the immunosuppression factors. Lung requires high level of immunosuppression compared to other organs. So we have to know the effect of immunosuppression on cancer recurrence. There are certain medications which have the tendency of proliferation, so they can cause cancer to recur. And we also should know that how much period of cancer-free survival the patient is having. So we should consider all these factors and then decide on when to transplant after malignancy. For example, this was a 72-year-old male. He was an IPF based on clinical radiological criteria. He also has a past medical history of hypertension, dyslipidemia, GERD, and he was an ex-smoker of 30 pack years. He got admitted with a ILD flare in August 2021, and he was requiring 10 to 15 liters per minute of oxygen with exertion. He was assessed and listed for transplant in December 2021. So when we have done a routine CT chest, after this was at the time of initial assessment, and after 3 months, when the patient is on waiting list, we noticed that this lesion, which was a suspicious lesion initially and not very indicative of any malignancy, the lesion has progressed. So now this lesion has high suspicion of malignancy. Now the question is whether to transplant this patient or not transplant this patient. So to further guide us, a PET scan was done. The PET scan was showing a nodule of 13.3 SUV in the left lower lobe. So there were no other positive notes and no uptake in any of the lung fields or in the rest of the body. And so pre-lung transplant, short course radiation for stage 1 lung cancer was given. 12 gyri delivered in 3 fractions, and the patient was listed for lung transplantation again 7 days after the last radiation. And the ongoing surveillance was carried on while the patient is on waiting list. And 2 months after radiation, luckily this patient got a lung and underwent bilateral lung transplantation, and the explant was a poorly differentiated squamous cell carcinoma with negative nodes. So this is like a therapeutic treatment for patient for both the malignancy and the ILD, but this is not the case in every scenario. So in case of any localized malignancy, we should be careful that there is no extra pulmonary dissemination of the malignancy, and we should see that the resection of this lesion is a permanent curative of the patient, both in terms of malignancy and the pulmonology disease per se. And the second one is like uncontrolled infection. Usually in sepsis or septic shock, we usually won't do transplants. But in very rare cases, like if the disease is localized only to the lungs, then usually, and if the lungs can be removed, and because they are the primary source of infection, in those scenarios, we can usually do a lung transplantation. This is a very rare case which was published in a journal which was done by the Toronto Lung Transplant Program. This is a 32-year-old female with Bordetella cepacia negative, who's a case of cystic fibrosis. She was a good candidate for transplant, but she developed subsequently H1N1 influenza and she required intubation. She was kept on ECMO, VV ECMO, and listed for bilateral lung transplantation. But 10 days down the lane, there was worsening of shock with MDR, pseudomonas, sepsis, and lung was the primary source for all this. So she was requiring maximum pressure requirements, and slowly she started developing AKI, liver issues, everything. So multi-organ dysfunctions slowly started developing. So at that time, the team has decided, had a discussion with the ICU, the medical team, the surgical transplant team, and the family. And finally, they have taken a bold step of bilateral pneumonectomies, which is unthinkable. So, to pursue the source control, bilateral pneumonectomy was done, and the patient was kept on central VA ECMO, PALA Nova lung. And after 5 days, and after the source control, hemodynamics and organ function have improved. And 5 days later, she was transplanted. There was a bilateral lung transplantation was done after 5 days, and she was decannulated from VA ECMO. She was discharged hospital from the hospital 4 months post-transplant. So this is a very rare case of controlling lung infection and doing a lung transplantation, which can be done in only centers with high volumes and good expertise. So whenever we see these cases, usually we'll try to avoid, because we have much more multi-resistant organisms compared to the Western population. So if there are severe infections, or if the infections are bad, I think it's better to avoid taking those lungs and accepting accepting that patient as a recipient. And compared to these absolute contraindications, there are certain other factors with substantial risk to post-transplant outcomes. So these factors should, if the patient is possessing these factors, then the transplant should be done only again in a center with much expertise. And if there are more than one of these risk factors, then multidisciplinary approach is required, and optimization of the patient is also required. First of all, the age of the patient more than 70 years. Usually the guidelines say that age of more than 70 is usually a relative contraindication. There are certain aspects of why it is. If the patient is physically conditioned, if he doesn't have frailty, even patients more than 70 years can be accepted. But these patients, we need to work out on their osteoporosis, and if the bone mineral density is good, and if they doesn't have significant osteoporosis and significant age-related cancer screening was done, then I think that's fine to take these patients. And if the patient is having severe coronary artery disease that requires a bypass surgery, so then both the bypass and the transplant can be done at the same time. Along with that, one important thing is a significant, like severe esophageal dysmotility, which we usually see, like all the GI issues in connective tissue disease related ILDs. So in these patients, we should have a preoperative plan of what to do to prevent the complications after the transplant. And next important thing is like a BMI. If the patient is obese or overweight, or if the patient is underweight, then we need time to optimize the patient so that we can have better outcomes after the transplant. And if the patient is having limited functional status, or if the patient is having psychiatric or psychological or behavioral issues, then I think these are all relative contraindications which need optimization prior to the transplant. Apart from these routine things, there are infections like Mycobacterium abscessus, Burkholderia, hepatitis B or C, and chest wall or spinal deformities. Pre-transplantation, I think it'll take a lot of time in our country to think of retransplantation at this stage now. So all these are things which needs further stabilization, because the guidelines are from International Society for Heart Lung Transplantation. They stress more on Mycobacterium abscessus, but in India we should know more about Mycobacterium tuberculosis, which is much more common here. So I'll go through the Mycobacterium tuberculosis in the coming slides. So few of these I'll deal in detail, like atherosclerotic disease, coronary, peripheral arterial or cerebrovascular disease. Patients with mild to moderate or revascularized coronary artery disease may not have worse survival. So whenever a patient, like elderly patient like 55 to 60, if we take that patient for a transplant, and when while assessing the patient, if we find that the patient is having a coronary artery disease, then we should decide whether we can stent the patient or whether we have to do CABG at the time of the transplant. That depends on the severity of the lung disease. If the patient's lung disease is bad enough that the patient is won't be able to make it 1 month down the lane, if the disease is unpredictable that the patient cannot survive beyond 1 month, then I think it's better to plan for a CABG at the time of transplant. But the patient, if it is stable, if the patient is stable enough, requiring only 1 to 2 liters of oxygen, not an immediate candidate for transplant, like not an urgent listing for the transplant, then for those patients, we can do stenting, wait for 1 month and then reassess and then list again for the transplant. And in peripheral vascular disease also, if the disease is very severe, that limits the mobilization after the transplant or causes some restriction to the rehabilitation of the physio after the transplant, then I think it's better to reconsider and optimize these patients before the transplant. For example, this is a 59-year-old male with a diagnosis of ILD, likely idiopathic pulmonary fibrosis. This patient had a recurrent pneumothorax with a chest tube and ongoing air leak. So persistent air leak, chest tube, and IPF. So this patient was referred for an urgent lung transplant consultation as his oxygen requirement kept on increasing. So while evaluating, it was found that he had flow-limiting lesions in LAD and OM1. So then, if we do stenting at this point of time, it requires 4 to 6 weeks dual antiplatelet therapy. So cannot enlist the patient until the patient is off clopidogrel. But currently the patient is requiring 8 liters per minute oxygen at rest and 15 liters per minute with minimal exertion. And there's an with ongoing air leak on topaz, and mobilizing with physiotherapy is a bit difficult for this patient. So what are the issues with transplanting this patient and not transplanting this patient? So finally, it was decided to transplant this patient with concurrent CAB, coronary artery bypass surgery. Because if we don't transplant this patient now, then the risk of empyema because of the prolonged chest tube, and second thing, unpredicted trajectory of the interstitial lung disease, like predominantly IPF, we cannot predict what happens next. And along with that, if we have to stabilize the patient and improve things more, then at least we have to do fluoridesis, which is relatively, if we do fluoridesis just immediately when the patient is at this stage, during the time of surgery, there will be a lot of adhesions and it increases, prolongs the surgical time and also causes bleeding. So for this patient, so the decision was to do a transplant along with the CABG at the same time. And other important thing which we need to consider while doing a transplant is assessing the GI condition of the patient. That means whether the patient is having gastroesophageal reflux disease or low esophageal motility disorder or anything, we need to definitely assess, because esophageal dysfunction and GERD or delayed gastric emptying have very worse outcomes of post-transplant, worse post-transplant outcomes, because they are going to trigger rejection, and that is one of the reasons for chronic lung allograft dysfunction. So preoperatively, things have to be worked up regarding if the patient is having any signs or symptoms of gastric reflux, or if the patient is on any of the PPIs, which for his gastric symptoms, then definitely we need to assess, like with the 24-hour pH monitoring, gastric emptying studies. And in patients like scleroderma, they have esophageal dilatations. So for them, we all should also have a plan of the post-operative GI issue management, like a G-tube or post-stomach, post-pyloric tube feeding, like nasojejunal conversion to gastrojejunal, or in patients with hiatus hernia, or in patients who have significant dysmotilities, we have to consider anti-reflux surgeries pre or post-transplant. So, or we need to have a plan in patients with GI disease. So it's optimization of the GI disease along with the plan pre or post-operatively will definitely improve the outcome of after the transplant. But definitely presence of some GI issues is not a contraindication for transplant. And apart from that, again, infections play a major role, like tuberculosis in our scenarios. So we should treat the patient with tuberculosis intensively pre, and should have a post-transplant treatment and surveillance also. So it's not that the patient is a case of ILD or bronchiectasis. If the patient develops tuberculosis while on the waiting list, then we cannot wait for a whole 6 months to list the patient. So what is the criteria? Like we have the patient should tolerate the medicines, one thing, and second thing, AFB smear should be negative. Culture, we need not wait for the culture to come negative as such, but initially at least 2 months of intensive phase is reasonably good to consider for transplanting. Apart from that, significant infections with a mole like non-aspergillus mole like Scerosporium, Glomentospora, these are like difficult to treat infections, and I think it's better to avoid people with these infections. And in patients with cystic fibrosis, patients with Burkholderia cepacia carry high transplant mortality. So they need combination antibiotics along with sinusitis management. So these are the major things which we need to keep in mind while transplanting a patient with these infections. And all these should be done in centers where we have a transplant infectious disease expertise. So we have discussed about absolute contraindications and relative contraindication, and then these are few other issues which pose some risk to the patient outcomes. But we need not, what I say that we need not consider abstaining from transplanting these patients, but we need to have a proper plan in these patients. In all this, I think I can just I'll elaborate about the connective tissue diseases. Connective tissue diseases, we need to just look out carefully what are the extra systemic manifestations and how significant and severe the disease is limiting the patient's ability apart from affecting the lung. So, for example, in scleroderma, it affects apart from the lung, it also affects the skin. Chest skin is too tight that it's difficult for the surgeons to stitch over, or it is difficult if there are high chance of dehiscence after the transplant, then I think that poses a very difficult issue for the surgeries. And there are certain ILDs like rheumatoid arthritis which can recur after the transplant in the transplanted lung, but because of the immunosuppression what we give after the transplant, usually that should not be much problem. So there are certain conditions which we need to carefully monitor and manage and optimize prior to the transplant. And after going through this muddy water, let me just start on the actual indications for transplant referral and listing. General conditions like general considerations, when is referral and when is listing. There are two terms like referral and listing. Referral is the term when we use like when we refer a patient to the transplant team. And listing is the term which can be used like when the transplant team keeps this patients when this patient is decided by the transplant team to transplant the lung actually. So that means if the patient is referred to the lung transplant team, it doesn't mean that at that time this patient is actively into the transplant. So there is a huge amount of waiting period between the referral and the listing. But referral is very important because if we refer a patient to the lung transplant team early, the early referral facilitates time for educating the patient and to optimize the patient. And if the patient is for multi-organ transplants, then that because of the longer wait periods, I think early referral is definitely indicated. And when do we refer a patient for lung transplantation? If the risk of death from the lung disease within 2 years is more than 50% without lung transplantation, or if we think the survival of the 5-year post-transplant survival of this patient is more than 80%. So these are the criteria when we refer the patients for lung transplantation. So now the disease-specific considerations for transplant referral and listing, COPD. So this is a brief case scenario. Mr. XX is a 59-year-old male with severe COPD. He was diagnosed 10 years ago with worsening of symptoms. Diagnosed 10 years ago. Now, since last 4 to 5 years, he had worsening of symptoms. He was a smoker, 40 pack year, but quit 5 years ago. He doesn't have any occupational exposures. Recently hospitalized, but historically he had multiple exacerbations per year. He is MRC4 and he also needs assistance with activities of daily living. He uses 2 liters of oxygen at rest and 6 liters on exertion. He is on nocturnal BiPAP currently and is also undergoing pulmonary rehabilitation. Of late, his oxygen requirement increased to 15 liters per minute on exertion, like saturating around 78% to 83%. So this is a classical case of very severe COPD with recurrent exacerbation. So definitely this patient, this is his X-ray and his FEV1 is like 0.56 liters. So definitely this patient's board index will be more than 7. So in these patients definitely this is the time of listing the patient, referring and both the referring and listing the patient. So in general, the guidelines say that COPD patients, when you come across a COPD patient with a board index of 5 to 6, who is a frequent, along with the additional risk for mortality, like frequent acute exacerbation and increasing bold index more than 1 point over the last 24 months, and pulmonary artery to aorta diameter more than 1 on CT scan, and FEV1 20 to 25% predicted. If we find these qualities along with the poor quality of life, then we should consider concurrent referral for the we should consider referring for the lung transplant team. Along with that, we have to search for other options of stabilizing the patients like lung volume reduction surgery or a biological LVRS. And when these patients will be listed for the transplant, that means once the patient is referred by a respirologist or a pulmonologist to the transplant pulmonologist, if the patient doesn't fall into a bit severe criteria, then we still observe and manage the patient on wait list. But when the patient's board index is between 7 to 10 and if the FEV1 is less than 20% predicted, moderate to severe pulmonary hypertension with severe exacerbations requiring ICU and a chronic hypercapnia, then that's the time the patient will be listed and will be in the active wait list of the transplant team. So this is regarding COPD, and next comes interstitial lung disease. So this patient, this gentleman is about I think 59-year-old, was diagnosed with ILD in 2020 after presenting with cough and dyspnea. And he had, after diagnosis, he had this declining respiratory status over the past 2 years, with most significant declines occurring after 2 hospitalization for apparent ILD flare. And his now condition is like his MMRC class 3 and oxygen requirements are at 3 liters at rest and 8 to 10 liters with exertion. If you find such patients, then I think it's ideal to refer directly to a transplant pulmonologist without much delay. And in interstitial lung disease, specifically IPF, once you diagnose the patient with IPF, I think it's better to have a talk with the transplant team regarding this patient to just initiate the discussion of lung transplantation down the lane and just to educate the patient more about transplant options because of the unpredictable nature of the disease, and we never know when will be the accelerated phase or when they decline suddenly, or any viral infection can trigger this worsening of ILD and can trigger ILD exacerbation. So it's better to have a discussion with the transplant team and keep managing the patients. And once the patient reaches certain stage, like decline over a 2-year period of FVC more than 10% or DLC more than 15%, and the patient is requiring supplemental oxygen at rest or exertion, then it's the time to refer the patient for the lung transplant team. And the patient will be listed if the decline over a 6-month period of FVC more than 10% and DLCO more than 10%, and if the 6-minute walk distance decline is significant enough, and if the patient develops pulmonary hypertension, repeated exacerbations, then this patient will be actively listed for the transplant. And cystic fibrosis, which is most common in the Western population and in the northern part of our country, then the timing of referral will be FEV1 30%, less than 30%, or if the patient is having an FEV1 less than 40 with coexisting features like a low 6-minute walk test, hypercapnia, resting or exertional hypoxemia, pulmonary hypertension, and massive hemoptysis requiring embolization, pneumothorax, and diffuse involvement of the lungs. So all these are the criteria for referral. And for the listing, like apart from the general referral criteria, then when the patient worsens and is continuously on oxygen and requiring repeated antibiotics, then at that time the patient will be listed. Even bronchiectasis, non-cystic fibrosis, bronchiectasis, also the same features will account to. But when a patient is a female or a short stature, or the patient is having antibiotic resistant organisms like Bordetella or MDR, TB or NTM, then I think it's better to refer a bit early, because finding lungs for these patients is a bit difficult, and optimization of this patient is much more important in considering the transplant than the other part of the subset. And now coming to the pulmonary artery hypertension, there's a reveal score which says the severity of the pulmonary hypertension. So if the reveal score is intermediate or high risk, or reveal score is more than 8 despite maximum pulmonary artery hypertension treatment, so then it is the time to refer, or a significant RV dysfunction, or if the patient is requiring a parenteral prostacyclin, progressive disease despite therapy, or secondary liver or kidney dysfunction, or life-threatening complications such as recurrent hemoptysis. If the patient is having the above-mentioned criteria, then it's a time to refer the patient for lung transplantation. And will be listed if the patient is having progressive hypoxemia, and again the reveal score is more than 10, and the patient will be listed for the transplant. Coming to LAM, despite mTOR therapy, severe lung function abnormality, exertional dyspnea, hypoxemia. So for all the interstitial lung diseases, if the patient is requiring oxygen, then that is the time to refer the patient for the transplant. And once the patient is referred, then based on the severities and everything, then the patient will be listed for the transplant surgery. And other conditions which are mentioned in the guidelines are like thoracic malignancy, which we very rarely see, like in situ carcinomas, minimally invasive adenocarcinoma, or if the surgical, in cases of bronchoalveolar cell carcinoma, if it is a localized disease only pertaining to the lung, then again a lung transplantation. If it is expected to be curative, then we can consider doing transplant. But otherwise, if it is a disseminated malignancy or something, we usually won't consider doing transplant for this patient. And the new indication for lung transplantation is ARDS. This is, the guidelines are in evolution, but as of now, the persistent requirement for mechanical ventilation or ECMO without expectation of clinical recovery to liberation. That means if we are not able to liberate the patient from mechanical ventilator support or ECLS, or early initiation of ECLS as a bridge to recovery or decision, because if the patient is between 10 to 14 days on ventilator, or if there's evidence of irreversible lung damage, or if there's a single system organ failure without involvement of other organs, then these patients with ARDS have to be considered for transplantation with ECMO as a bridge to transplantation. Example, this is a 52-year-old male with severe COVID ARDS in early 2021, intubated, paralyzed, prone. But as the patient was not improving, he was transferred for the consideration of ECLS as a bridge to the recovery. So 6 weeks on VV ECMO, single organ failure, patient is awake, standing, he's marching at bedside, unable to wean ECMO further because he has become ECMO dependent and his lungs are badly damaged and not recovering as such. And he was assessed and listed for lung transplantation. But unfortunately, 2 weeks after listing, he developed acute headache, vomiting, and loss of, there is reduced level of sensorium. And at that time, because ECMO has its own complications, so he had an intracranial bleed, and he was again delisted for transplant because intracranial bleed, we cannot transplant these patients with intracranial bleeds. But this is not the end of the story. So urgent posterior fossa decompression was done, CSF leak, there was a drain insertion for the CSF leak, and he was kept on meropenem and vancomycin. And 1 month after decompression, he had bilateral subdural hematomas and he was treated conservatively. Luckily, this patient survived all this episode and was decannulated from ECMO after 5 months of the support. And then he was transferred to the home hospital and to the rehab with oxygen and support. And this patient 1 year later walked into the hospital for lung transplant reconsultation as he was still requiring 5 liters of oxygen. And for this patient, bilateral lung transplantation was done 20 months after listing once the patient got lungs. So it's we need not, if the patient develops some complication during the ECMO, it's not the end of the story, and we need not narrow down our opportunities, we can still have a positive hope, but these occurs in very rare cases, but still there's a lot of chance and hope for these patients to get a lung transplantation. We have seen, I think, a lot of COVID patients during the pandemic, and a lot of patients had fibrosis requiring oxygen support down the lane. So all these patients can be considered for the transplantation, even if it is not in the acute phase down the lane. If the patient is having this underlying oxygen requirement, then they're still candidates for lung transplantation. So once the patient is referred to the lung transplant team, they will decide whether whether the patient has to be listed or not. Okay, so what all things the transplant team needs to assess the patient to list for the lung transplantation. Once a patient is sent to the lung transplant team, then we usually will review the consultation, all the previous notes and the PFTs, 6 minutes, chest imaging, the medication list and everything, and then talk with the patient. We'll keep an appointment with the patient. If the patient is requiring oxygen and if the patient is far away, then we can even have a video consultation, or we can have a direct consultation if the patient is nearby. And after that, so these are the bunch of tests which we require to assess the patient. Like apart from the routine pulmonary function test and 6-minute walk test and chest X-ray, we also need a quantitative perfusion scan, blood work, ABG, sputum culture, tuberculosis scan test, echo, cardiac stress test, coronary angiogram, predominantly the right heart cath, and carotid and femoral arterial Doppler, bone density, and cancer screening. So all this bunch of investigations will be done to the patient once they are referred to the lung transplant team. And based on these reports, we have to decide whether the patient is suitable to be listed for the transplant. Then there will be one coordinator pivotal to every team. The coordinator will arrange all the things like assessments between different teams. So a physiotherapist, cardiac and lung transplant anesthesiologist, other specialists like ID, gastro, the dermatology, gynecologist for female patients, and if the patient is having any connective tissue disorder, a rheumatologist opinion, so other specialists as needed, and along with a social worker, like the coordinator can take that job, along with the dietitian and the psychiatry team and the transplant surgeons and the transplant pulmonologists. So all of them will see the patient independently and will meet and decide on whether to transplant this patient or not. So physiotherapist may come with an opinion that he needs more rehabilitation before listing, or the patient is adequately conditioned enough to list, and if the coordinator may come with that patient is having good financial support and good family support to support him, and the dietitian may come and say that BMI is okay, he's okay, he can be transplanted, or BMI is low, he needs more diet, or the BMI is high, he's obese, and so he needs to cut down on the weight, and physio team will assess and tell them the exercises and everything. And so the surgeons can decide on whether they want to do a single lung or bilateral lung, or which side of the, if it's a single lung, whether it's a right or left. So all these discussions will be going on during the listing committee meeting. And finally, a decision will be made whether we can list this patient for transplant or not, or if we are listing how severe the patient's condition is, so how soon we should transplant, whether it's a status 1, like the patient is requiring only 1 to 2 liters of oxygen, or an immediate risk like 2 to 4 liters, or a high risk like 10 to 15 liters, or admitted in the hospital, or is on ventilator support or on ECMO, and whether we have to consider ECMO bridging as a bridge to transplant if the patient worsens. So all this will be discussed in the assessment meeting, and a final decision will be given to the patient like, yes, you are listed, but in this stage you are at stage 1 or stage 2 or stage 3, and we consider these we want further these investigations, or we need these optimization, and everything will be conveyed to the patient. So after this assessment and everything, it's not that we get lungs immediately after we list the patient. So during the wait list, how to manage these patients? Usually these patients will be managed by the primary respirologist who refer the case. So, but every 3 months, we need few investigations to keep an eye on the patient. So every 3 to 4 months, we need to have a CT empty chest, because as in the case scenario which I have mentioned, that there was a suspicious nodule later developed into a well-defined nodule. So we need to have a close eye on COPD. They are smokers and high risk for malignancy. So we need to have a CT chest every 3 to 6 months, and blood work frequency depending on the condition like ILDs, CTI, connective tissue ILDs, and 6-minute walk test every 3 months, and PFTs every 3 months, and HLA antibody testing also every 3 months to decide on how the patient's antibody development has been turning on. Because patients, if they receive some blood transfusion in between, then definitely their HLA testing will change. So all these updates need to be given to the transplant team, so they can be managed with a primary respirologist with these tests every 3 months, and an update to the transplant team every 3 months, like about the patient's condition. And along with the regular medication management, there is a very important thing which improves the patient outcome. Like it's like a rehabilitation. It's rehabilitation at least 3 times per week for the entirety of time on the wait list. If we start listed the patient now, every week 3 times the patient should undergo rehabilitation. Either patient can go to the nearby place, hospital or a clinic where rehabilitation is going on, or the patient can do a virtual rehabilitation 3 times per week, which allows ongoing optimization and assessment of the patient's condition. And most important is the palliative care for lung transplant, because they have significant symptoms of intractable cough and breathing difficulty. So I think it's better the symptom management is definitely better. We don't have a palliative care teams in our setups, but I think the respirologist can do all these things like managing the cough, managing the dyspnea with various measures what we have, so that the patient will be a bit more comfortable prior to the transplant and can participate more in the rehab, so that we can list him properly for the transplant. So, and along with that, during the wait list, the patient should be given an adequate support from the dietitian point of view. Also, if there is any high or low BMI, both carries increased risk for poor outcomes. So if the patient is having low BMI, then the dietitian will follow him up regularly, give him adequate high protein diet, good nutrition, or a high BMI, then vice versa. So the psychosocial team and the support groups will meanwhile manage the patients during the wait list. So during the wait list, the management by the respirologist, the physiotherapist, and the dietitian play an important role to keep the patient conditioned and to follow up the patient during the wait list period. So with all these issues, the transplant team will decide on once the patient is on wait list. So a regular monitoring of the patient on wait list. Then when a lung comes, then the transplant team will decide on to transplant which patient. The lungs, they'll assess as which lungs suit to what patient, and then they can just easily transplant the patient with very good outcomes. So I just covered all these terms, which components which I've mentioned during the initial in the first slide, like general ethical and center specific considerations, contraindications, indications, and how to assess the patient after referring, and how should we manage during the wait list. And this is an amazing quote, like transplantation is an amazing journey that tests the limits of human strength and courage. It requires commitment and faith, as well as mental, emotional, and physical endurance. If you can handle lung transplantation, you can conquer anything you set your mind to. It is one of the life's greatest challenges, and among the rewards is life itself. So thank you again, everyone, for giving me this opportunity, and I'm ready.
మేడం కనెక్ట్ అయ్యారా?
Yes, sir.
Are you there?
Hello, Chaita.
Hi, sir. I miss being there.
ఎంత అయిందిరా, టైం ఎంత అయింది?
10 o'clock morning.
Okay. So nothing more to ask on listing and referral, because anyway you elaborated so much. So
Thank you, sir.
so point is, how often you are seeing acute rejections there, hyperacute rejections there?
Sir, our rejections are more here because they transplant wide variety of populations and different ethnic backgrounds avanni ekku untai kabatti there is a lot of rejection which we see here, but comparatively I think it should be less in our country because of the similar manaki race kani ethnicity kani similar background kabatti I think possibly should be much less in our scenario. Ikkada they see a lot of rejection because they get lung from different population, they transplant it to a different race and different population, so the rejection is a lot more here.
But all they will go through the major histocompatibility complex, no?
Yes.
But
HLA, we usually do just prior to the transplant. When the deceased donor lung comes, then they get a sample and do the flow cross matching here. And after that, usually will be done at 3 months interval, and after that at 6 months, 9 months, and 12 months. At least for 1 year, every 3 months, they'll be monitoring HLA. And if the patient develops any worsening of lung, his symptoms like breathing difficulty or cough, or if the patient's lung function, pulmonary function declines, then at that point of time, a repeat HLA is warranted.
Okay.
But we usually, if there is rejection, it's not like that this lung is going to get rejected. If it is an antibody mediated rejection, then there are ways to improve that part of rejection. Like here, they do plex. They will give IVIG to block the antibodies, plex to remove the circulating antibodies, then followed by IVIG to block the antibodies, and then thymoglobulin to suppress the T cells.
Does it have any effect on induction therapy? How often? See, what is your protocol in your initiate?
Yeah, actually at Apollo, we usually give besiliximab as an induction therapy, followed by the routine immunosuppressant besiliximab and a dose of steroid, followed by tacrolimus and mycophenolate. Here, they usually don't give induction therapy because various studies have proved that besiliximab is not a very good induction agent. So they usually give a pulse steroid before the 500 mg of methylprednisolone before the surgery, and after that, a regular immunosuppression with tacrolimus, mycophenolate, and steroid.
Changing drug is not the point. Is changing drug is not the point of interest here. Does induction therapy will leads to infections, more infections?
Besiliximab, I don't think so. It doesn't cause so many infections also, and it is not a very good induction agent. Even if we give besiliximab, we should start the medication as soon as possible. Like tacrolimus should be started immediately after the surgery, but it gives some protection to the kidney, but is not very high in infections. But if we give thymoglobulin or some other potent monoclonal antibodies, then they have definitely high risk of infections.
Okay, right.
Hello, Chaitanya.
Hi, ma'am. Hi, Sunil sir.
Hey, Chaitanya,
go
you
ahead,
responded to whom?
Yeah.
Sunil sir has sat down.
No, you please carry on, ma'am.
Hi, Chaitanya.
Madam. Hi, madam.
After selection of the patient, anybody has ran from you that we can't help all these rehabilitation programs and why to go for lung transplant?
Yes, madam.
Do you come across any patients like that?
Yes, because in our place, financial constraint is a major issue because we don't have transplant programs in government setups. So first thing occurs only if the patient can afford transplant. Unfortunately, that we have that scenario as of now, but if things improve, then I think down the lane we have to do in government setups also, as how other transplants have been progressing. So during initially during the start of assessment, patient will be on 2 liters and they'll be having a lot of hope that they're going to get the lung soon. But as the time goes on, if the patient is not getting the lung, meanwhile, if the symptoms are getting worsened and if the family is already restrained of financial constraints or something, then they usually opt out sometimes that no, we cannot afford more. And sometimes even if they're willing to afford, the patient will be so deconditioned that he may not be a candidate, right candidate for transplant. So all of these things happen in the wait list time.
Do you have come across a healthy lung before COVID who have gone for lung transplantation post COVID due to COVID?
Yes, 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 yes.
Those
Lot
have
of
a
patients.
good
Even at
response?
Apollo, we have done. Long-term outcomes are not as good because it's only 2 years, but they are facing. I'm there here now, so what I have seen that this is a very experienced center, but despite that, COVID patients are not doing remarkably well as the regular IPF patients. Apart
Okay.
from lung involvement, I think they have much systemic involvement also, so they are not doing. They're still 1 year down the lane. They're still getting recurrent admissions because of rejections, infections, and somehow their lung function is not to the par as compared to other IPF patients.
Okay. Nice talking to you.
Thank you. Nice
Yeah,
talking to you.
good morning and good evening, Chaitanya.
Hi, sir.
Yeah, how are you?
Good evening. Fine, fine, sir.
Yeah, I
Thank
am
you.
very
Thank you
happy.
for conducting this one.
Yeah, well, I'm very happy when I saw you last time in Hyderabad Apollo. Now I'm very much elated also to see you as a going consultant and along teaming up with Dr. Naresh sir and Nirja madam and doing a lot of job. And you have become a role model for the young generation pulmonologist also. Thanks for being
Thank you,
there.
sir. Thank you.
My doubt is that, as you said, post-COVID fibrosis, after how many months or years of post-COVID fibrosis would you like to take the case for lung transplant?
Sir, అర్థం కాలేదు. After how many?
How many months or year? How much time after post-COVID onset of
Months or
post-COVID?
years? Okay. Sir, depends on the severity of COVID. If the COVID is like they are able to pass to that acute phase and requiring only minimal support, we can wait till the patient, because apart from lung, they have significant neuromuscular weakness also. So till they are able to walk and do something, then we can consider. But there are a lot of acute situations which happened during COVID that patient was not able to wean off from the ventilator. So in those case scenarios, at least if should not wait long enough that the patient will be totally deconditioned, so that at least 4 weeks after the COVID onset, if the patient is still ventilator dependent or if the patient is still ECMO dependent, I think that's the right time to consider transplant.
But some of the post-COVID fibrosis also getting spontaneously or healed up. So that is why my question is how long we should wait. So you said it's a 4 weeks or so. It's okay, great. So next question is, what is your take on benefit of transplant in autoimmune disorders? Because disorder is autoimmune. We'll discuss with Dr. Neerja madam, but what is your take on that?
Sir, autoimmune diseases, patients with autoimmune diseases are doing equally well as patients with interstitial IPF or any other non-autoimmune diseases. Only rheumatoid arthritis has some recurrence, but because they are significant immunosuppression post-transplant and all these are immunomodulators, so that is not causing much risk. Only patient problem occurs with scleroderma, where they have significant esophageal dysmotility, and GERD is one of the highest risk factor for causing lung rejection because of microaspiration, and along with that it also induces antibody production. So that is the only thing which we need to consider and optimize before the surgery. And MDA5 is a polymyositis dermatomyositis is the one which is posing some problems to the patient because somehow they are not doing fairly well enough as the other patients.
Okay. So can we perform simultaneously with the multi-organ transplant also along with lung transplant? What is your experience?
Yes, sir, absolutely. Multi-organ transplant is going on when a patient is having liver cirrhosis. Along with that, if the patient is having an ILD, then definitely liver and lung can be given to the same patient, which is more feasible in our scenarios than the Western population.
Okay. Has there been any trials on lobar transplant, lung lobar transplant?
Yes, whenever that usually will be done in patients in females or with short stature, we usually won't get for them. If we have to get lungs, then we have to wait for the similar age group like 16 or 18 or a pediatric lungs. So for these patients, what we
Okay.
usually do, take the adult lungs. If they're ABO incompatible and HLA match positive, then when HLA matching is there, then we usually do a either anatomical resection like a lobar reduction or non-anatomical size reconstruction like a wedge resection of certain lobes, and we can transplant.
Okay, that's very nice of you. Thank you very much for clearing all the doubts. So when you come back from US, don't go to Apollo directly. Please come to
Yeah,
Chest
I'll
Hospital, clear all
sure,
the
sure,
doubts of
definitely,
Dr.
sir.
BMS Pathrudu, and then go to Apollo.
Yeah.
Just be online. Thank you, thank you.
Chaitu,
Thank you, sir.
how about living donors? How about living donor transplant?
Sir, living donor transplantation, usually manam adults lo kante we do usually in pediatric patients with in pediatric cystic fibrosis kani
No, no.
pediatric congenital.
How often you are getting there, living donor?
No. Here we are not doing lobar transplantations, living donor transplantations at all. They
Okay.
have not done even a single transplant, but that is happening in Japan, where if the child is having a significant congenital lung issues like cystic fibrosis or something, one lobe from a mother will be given to the child or something. They are doing lobar transplantations are occurring in Japan, not in Toronto.
Okay. The other question I want to ask is, do you have any opportunity to see when the patient is at the intubation side? In the OT theater, have you seen a case, no?
Yes, sir.
Oftentimes the patient will crash, no? Will they keep the
Yeah,
patient?
that's the reason intraoperatively VA ECMO, they'll keep on VA
That's
ECMO
what.
prior to the transplant.
When the
Yes.
patient is an ECMO only,
And
they will intubate, right?
yes. First VA ECMO will be kept, they'll be intubated, and after the surgery, then
case
ECMO
man,
decorrelation will be done.
Hello, Chaitanya, can you see me?
Hi, sir. Yes, sir. Hi,
Yeah,
sir.
Yeah, I just wanted to ask you one question. We keep seeing a lot of elderly patients coming for referral.
Yes.
Yeah, even
Yes.
in the Indian scenario, we see healthy people. They are like 65 years, 69 years. And
Yes.
what would you consider, whether single lung transplant or bilateral lung transplant?
Sir, if they are good enough physically, they are conditioned well, we can either go for a single lung transplant or double lung. Only if the patients are having severe pulmonary artery hypertension, we have to go for a double lung. Or if the patient is having doesn't have a pulmonary artery hypertension, and if he's doing reasonably good, we can either go for a single or double. Whatever it is possible for the at that situation, we can go accordingly, sir. Age doesn't decide as such here. But only we are seeing that they transplant even 79 or 80-year-old patients here, but the sternal, because of osteoporosis, sternal dehiscence is the most common thing what we are facing over here. But otherwise, I think they are doing reasonably good enough compared to the younger population.
Yeah, that is the thing, because normally we are doing all clamshell incision, where we are cutting both
Yes.
the chest and also the sternum, and
Yes,
also
sir.
when we go for a single lung, we can just do it with a thoracotomy, and
Yes, true.
sometimes we can avoid using the ECMO also, but it is always better to use ECMO, and we feel that elderly people can also be offered transplant, a single lung transplant, and as far as outcomes are concerned, I think they are equally good in comparison with bilateral lung transplant.
Yes, sir, absolutely. Especially in case of ILDs, we can just opt for a single lung transplantation if the patient is elderly, because the intra-op period duration is less, and outcome they because they have their own one native lung, so tolerating one single lung is much easier, as you said. So, and that doesn't require a clamshell also. So I think the outcomes will be much better.
Okay. Patu, any closing remarks?
Thank you very much. Thank you. So let me see.
Thank you, sir.
Right. No. Who is asking? No. Praveen, na? Come.
Sir, ekkada nunchi
Okay. You.
Hi, Praveen.
Hi, man. Good evening, man. How are you, man?
Fine, Praveen. How are you?
Fine, man. So my question is, madam, after doing lung transplantation in ICU and post ICU, how many days on an average the patient is kept?
If everything goes on well, 10 days we can discharge the patient.
10 days. So Fine.
3
very
days
nice.
in ICU or 4 days in ICU, and we can just shift him out of the ICU. I'm not saying about Toronto. It happens usually in our place also. Like if everything goes on well, patient comes out of the patient weaned off ECMO intraoperative after the surgery and comes onto the ventilator. Next day he will be extubated. Will be on 2 to 3 liters of oxygen, and within 3 to 4 days the chest tubes will be removed. Or even if 1 or 2 chest tubes, we can shift him to the ICU, mobilize, and within 10 to 12 days we can discharge the patient.
Thank you, ma'am. Thank you.
Now, what's the incidence of post-transplant pneumothorax followed by placement of ICDs? Is such a case sir getting encountered? I mean,
No,
after,
sir. Usually
yeah.
they'll be kept on chest drains. 5 chest drains will be there after the surgery, almost apical and basal on left and right, and a mediastinal drain. So based on the leak and based on the amount of the collection every day, we'll be monitoring and then will be removed. But usually pneumothorax is not such a frequent complication unless and until the patient has airway dehiscence, which leads to a BPF and a pneumothorax.
So last question from my side. I think Dr. Naresh will going to tell us about it, but as a matter of fact, I'm asking you: is there any thoracoscopic retrieval of the lung donor from the donor, as well as
No, no, sir.
thoracoscopic lung transplantation?
No, sir,
VATS
because
associated.
we
VATS.
no.
Why so?
No,
Lobar
I
can be
don't.
done through VATS, no?
Yes, sir, but donor lung, if we spend more time on donor lung retrieval, the cold ischemia time will be prolonged. So all these we usually consider when we have when we want only a smaller incision, despite we don't care about the time. But in donor retrieval surgeries, time is more important. So we don't want a small incisions and prolong the timing. So it's like we do a bigger incision and we have to examine the lung from beneath and from all aspects also to note for any nodules, contusion, consolidation. So I think it's open and complete evaluation of the lung is more important for a successful outcome.
So anyway, you're taking a healthy lung as a donor. Then what is the meaning of doing a bronchoscopic assessment of the, because you're not
No, sir,
expecting
because
any.
every healthy lung means so there will be sometimes only mucus secretions which will pose as some infiltrates in the chest X-ray. And when we do a bronch, if you think that it's not purulent, if it's only mucoid obstruction, or sometimes in accidents there will be some blood clot or something. If you retrieve that and if you do a X-ray, if it is fine, then we can take it. It depends predominantly on the PaO2 of the lung rather than the chest infiltrate. So definitely a bronchoscopy is indicated to observe the airways, how they are. Is there any foreign body aspiration during accidents, or if there's any aspirated material from the GI, or is it only simple mucus plugging or blood clots? So definitely a bronchoscopy is indicated for that.
Do you take routinely some mucosal biopsy and frozen sections also, frozen biopsy reports? Is there any?
No, not for the donor, but post surgery, every 3 months, usually surveillance bronchoscopic and transbronchial lung biopsies will be done for the recipient, but for donor, no biopsies.
Okay. Is there any use of EBUS in donor lung?
No, sir. Donor usually that will be a very narrow window. During that time, all the teams will be ready to retrieve. So if there is any mediastinal node or anything, then that will be brought to the surgical team intraoperatively into the main hospital where the transplant is being done, and we can send that lymph node for its frozen section. We can wait for half an hour till we get the report, and if it is non-malignant condition, we can proceed. That happens usually. A lot of some nodules or some benign lung tumors also will be noted during donor retrieval. At that time, a frozen biopsy will be sent. If it is negative, we can transplant those patients.
So what is the waiting time in US for the lung transplantation?
I'm not sure about US, sir. Toronto, they have a good amount of donor pool because drug addiction is more here, and we get a lot of younger lungs.
Okay.
So people die by suicide, depression, and drug overdose. So
Okay.
more amount of lungs. Usually 3 to 4 months is a waiting period over here.
That's great. Thank you very much. Very nice of you. Thank you very much.
Thank you, sir.
That's wonderful, Chaitanya. Thank you once again.
Thank you, sir. Thank you, sir.
Thank you. All the best.
Thank you, sir. Thank you. Bye.
So I think it has been a little bit interesting, and I felt Sunil sir has been quite nostalgic meeting his student. So I will quickly now, most of the things I know is preparation for lung transplant is, most of it is almost we can say 70 to 80% of it is the pulmonology work and the post-op surveillance, pre-op, getting him ready. So much of teams involved. So I will just go through the surgical aspect. Most of my slides I can skip because I can take out the indications. Yeah, I will just go a little bit. So I just wanted to tell about the lung and combined heart and lung transplantation status in India. Is it working? So now, after going through all these talks, one important thing which I would like to tell you is we have in India there is a lot of challenges in establishing a proper lung transplant program, because it is like like in the US or in Europe there are specific centers where lung transplant is done in a particular area, and they cover a particular area, and all the patients are just referred to that center. So there is a particular center where both heart and lung transplant are done. So it is like a systematized system where sufficient rehabilitation workers and people who are counseling, people who are social workers, everyone is available. In an Indian scenario, it is really difficult because we have to get start a program. We need a lot of manpower and specialized manpower, and these specialized manpower are not trained. We have to educate them and train. Then, other than establishing a program, the next basic thing is availability of donor. So the availability of donors is another major issue, because we see patients, they are ready to donate. What we have been seeing over the last few years, they are ready to donate the liver and the kidney, but they will say no, heart and lung we don't want to donate. It is just because they are with their superstition that we don't want the chest to be open. So these we keep facing the problem, and sometimes they will be ready to donate, and we will see that the lung has got aspiration pneumonia because of road traffic accident. In the US, most of the donors are either due to cerebrovascular accidents or death due to drug abuse. So they have relatively, maybe they must be having a little bit of HBsAg or HIV, but the lungs are relatively better. In India, we have more of road traffic accidents, and by the time he has reached the hospital, he has already got a brain injury and he must have aspirated, and all his food which he has taken has already gone into the lungs. So, and most of the time what we say is lungs are not fit for donation. Then the next thing what we have been facing quite some time, even before the COVID area, is a late referral. The late referral, what happens is, because that is because the lung transplant program has not been there actively, and many of the physicians don't know about the outcomes, how it is going to be. So usually what happens is we get patients when they are in the late stage, and like when Dr. Pathulu was there, when we were with Dr. Cherian Center, we used to get patients from Gujarat and all like totally cachexic, and they are on 15 liters of oxygen, and they are not able to get up from the bed. And he was asking, when we induce the patient would suddenly collapse, the circulatory collapse, and we have to put emergency ECMO. So all these things used to happen. So what we have seen is, whoever has the patient, and more during and post-COVID, patients have got aware, and they themselves used to come to us, or come to different centers, or they would be asking the pulmonologist, why don't you consider lung transplant for me? What is the situation? So this, this is also one of the factor which is, which is affecting establishing a lung transplant program. Then there is another, which is reluctance to refer. Now, after the lung transplant has been done, we have to surely explain to the patient that you can get ventilator-associated pneumonia, you can get graft dehiscence, then you can get infections. Now, all these things is really difficult for the patient to take up, because if he gets a graft dehiscence, what we have to put stents, and it is like continuous visiting the hospitals. So like other programs, like a solid organ program, like a kidney or a liver or a lung or a heart. Heart, we can say, no, only rejection is the only issue. You will not, mostly get any infection, or you will not get no problems like lungs, because lungs is a thing which is always open to the atmosphere. And so we keep getting all these issues related to lung, and this has to be explained to the patient. So that is the reasons why we have all these. And most of the thing what happens is, when we talk of a financial package to the patient, we cannot include all these complications in it. So they come up added after the lung transplant has been done. Then we have a lot of logical and organizational issues related to lung transplant, because what happens is, if you have to transfer a organ donor from Chennai, or if you want to transfer from Bangalore to Vizag, the cost of transfer is going to be equivalent to the cost of the transplant. If you take a chartered aircraft, it is going to cost at least 15 to 20 lakhs to go to get the organ. So these are all the problems which are related to our thing. So slowly things are working up. So as far as organ donation in India is concerned, Tamil Nadu has been the leader, and it has been there for quite some time. Slowly Mumbai and Pune had picked up, and then Telangana is almost in the Telangana, and even before that the combined state also has been doing quite well, and it picked up a little bit in Telangana. So now slowly the organizational structure is being formed. The NOTO, or the National Organ Transplant organization, was not there. It is kept in place now. And then regional organ transplant for different regions, 4 regions have been identified, and individual state organizations have been put up. So as far as the organ donation factor is concerned, more and more awareness among the public and also the general public is needed for the purpose of getting them mobilized. Whoever is having a brain dead patient who has died, or a brain dead person. So these factors which have improved the organ donation is, one thing is government, by giving a very clarity on the Organ Retrieval Act is one thing which is needed. Then what the media do is, they give articles whenever an organ donation or a transplant is happening. They give good coverage. So this really helps in other people pledging themselves to donate their organs. And if which we have seen quite a few people also committing to that, by seeing someone donating, we have also come forward. Then police, or in the infrastructure, they provide green corridors and all. So this is also projected in the media, and in one way it gives a publicity for the organ donation program and also the transplant program. Our limitations, as I was telling, is transport of organ involving huge costs, and also geographical and logistical aspects. Sometimes it happens that we have to do a transplant, and the transplant surgeon and the team also have to travel to that place. So these are the things which are slowly picking up, and more and more surgeons and more pulmonologists and more anesthetists are all going into the program. And it should be, I think, even the government hospitals and medical colleges entering into the program, it should be it should not take much time to really pick up. So I will just go through some pictures, because it has been quite a bit of theoretical session till now. So this is a picture of a few pictures of heart transplant. This is a dilated cardiomyopathy, where we're just preparing for going on bypass. And then you can see, after going on bypass, we have excised the heart, how big it is. A huge one, like a bovine heart. And then you can see that it's almost the size of the jar, the big bowl, which so big it is. This was for a young patient. It was hardly 30 years old, dilated cardiomyopathy. She developed postpartum cardiomyopathy. Then what we do is, now this is the donor organ, which is being, like I was telling other time, we put it in ice, and for heart we have a separate preservative solution called custodial. We put it in that, and a double packed, so that the inside pack will be sterile, the outside pack will be relatively unsterile, so that no unsterile ice can be used, so that the temperature is hypothermia is maintained. Then when once it is removed, it is still kept in the ice slush, so that the cold ischemia time is not hampered. So after that, what we do is we place the heart in the side of the chest wall. You can see next to the retractor, and we are preparing for implantation. We cover it with ice so that it is not warmed up, because usually in the operation theater you will be having very warm lights, so it should not warm up the heart. And then the chest cavity, we first suture the left atrium, and once the most posterior structure, once the left atrium is sutured, then we go to the this is a short video showing that heart is being placed on, and we keep a sponge. That is the left atrium with its pulmonary veins and all. We have just disconnected them, and we suture it to the left atrial cuff, which is left inside for the patient of the recipient. So now I just want to show you a video of how the dilated cardiomyopathy heart looks like. You can see it is just like a bag which is just moving, it is not having any effective ejection. And then after that transplant, you can see it's so vigorously. We generally don't try to take out the heart, because you may go into some arrhythmia or something. So we can see immediate effect, especially after heart transplant. The patient is absolutely well recovered, hemodynamics, and sometimes they are more heart transplant surgery. We are able to finish it even quicker than our regular bypass surgery. So this is a small video showing, like, when we are doing a lung transplant, we need to prepare on the back table, keeping it the lung donor organ inside the ice slush. We identify the pulmonary veins, and we identify the pulmonary artery and all. So one video just showing the single lung transplant we did for an elderly patient, and that was a single lung transplant, and absolutely patient was, we did it on heart lung machine, because patient was relatively unstable as far as his saturations and all concerned. So that is the picture. You can see how the lung is pink and well perfused. Usually we can immediately come to know the color of the lung. If it develops any acute or hyperacute rejection, the color changes. It becomes little more pale, because the pulmonary vessels, the microvascular goes into vasoconstriction, and naturally the pulmonary artery pressures also rise. But if it is a pink lung, we know that at least hyperacute rejection is not there. So this is one video I just wanted to show you, is a combined heart and lung transplant we did for a primary pulmonary hypertension small girl, a small girl, maybe around 15 years. And she had severe, you can see how huge the RV and pulmonary artery are there. And we removed the complete, you can see the chest cavity is completely empty. There is no heart, and there is no lungs also. So this was the specimen, how they looked like. The heart was looking almost equivalent to the size of the lungs. So huge heart she had. And then this was the donor specimen. We can see the heart in the middle and both the lungs. Luckily, we got a similar sized organ for this girl. And this is the video just showing the operation being done. It's a little bit inverted, but you can understand it, I think. Yeah, continue, Chan. So that is the combined heart and lung. You can see both sides the lungs are there, and in between the heart. So we were just trying to orient the position. So what we do is we in the combined heart and lung, we have lesser number of anastomosis, because when we do a bilateral lung, we have to suture the individual bronchi, individual pulmonary artery and pulmonary vein. But here you don't need to suture the pulmonary artery and pulmonary vein. You just have to suture the trachea. and then suture the aorta and the superior vena cava and inferior vena cava. So it is a big procedure, but relatively less in the, as far as the technical challenge is concerned. So this is the last picture of it, where the aortic suture line is being finished. Then after the surgery, you can see that that is the final picture post combined heart and lung transplant. And it happened to be that we did the first combined heart and lung transplant in Telangana and Andhra, and we got a little bit of recognition from the state government and all also. So I just want to just skip through these slides. So while like we have been talking about, I think Dr. Chaitanya had given good amount of knowledge on all these things. Who are the ideal donors? Usually we consider less than 55-year age, but even elderly age can be considered. There is some extended criteria we say. In India we consider maybe up to around 60 years age. Clean X-ray, PO2 should be more than 400. Less smoking, that is less than 20. I think that is more than 20, I have given it wrong. So no chest trauma, and ET aspiration negative for gram stain or normal bronchoscopy. And whenever we have an extended criteria, we can always see where, suppose there is only mild chest trauma with only little bit of contusion of the lung, we can be considered. Moderate ET aspirations can also be considered. So these extended criteria we are not taking much nowadays, because a little bit, it depends on us, our experience grows, we can keep taking these extended criteria patients. So donor lung management strategy is also necessary. So whenever we have a a patient who is brain dead, we have to there is a protocol in which we need to manage the donor with strict protocols. So in that case, what happens is the lung, the PO2, which would be initially low due to some reasons, increased IV fluids being given when he was in post-trauma or anything, we can always manage by keeping him negative, by giving him some Lasix and keeping him negative so that the PO2 improves. And also there are other strategies like extra ex vivo lung perfusion, which is not so much available in India now. But at US and other countries, they are actively practicing. And still more things to come up, like lobar lung living donors, like living donors giving, which is mostly happening in Japan, and maybe happening in China also. So these are all the things which I would like to just recipient selection, referral and listing, which was extensively covered by Chaitanya. So early referral is one thing which I would like to stress. Once thing what I would like to tell is, if you have a patient of ILD, he is going on 2 liters of oxygen at home, I think he should be a little bit primed that you see things are going to get worse, so get prepared for something if you are really interested, and get to your finances organized, or keep talking to your children if they can, if someone is insured. And surely I think over a year's time or so, he will slowly get into 5 liters of oxygen. When he gets into 5 liters of oxygen, or on exertion, his saturations are coming down, he's not able to attend his daily course, like going into the bathroom and all, surely he should be referred to the transplant surgeon, and because it takes some time for them to really understand. They really don't want to come immediately for transplant. They think, I'm fine, why should I come now? I should come at the late stage. So these things, I think, early referral is one important aspect. And by attending several OPD encounters, it's not that just with one encounter he will be convinced and he will come. What we do is we talk to him, then we give him the nutrition, what he has to take, social worker talks to him, then there is a psychological aspect which the psychologist has to evaluate. Gastroenterology evaluation has to be done, especially what Dr. Chaitanya was telling about the gastric reflux studies, and all these are very essential. So early referral is one essential thing. And I will not go much about the disease-specific indications, like these all, all the audience here know better than me, because these are all more of the pulmonology area. So I would like to say which are the high risk recipients. Now, our high risk recipients are really elderly patients, where we would like to go for a single lung transplant if they are having only single organ involvement, not involving other organs like kidney, liver and all. If they are having multiple organ involvement, we will usually try to not list them for transplant. Then scleroderma with esophageal disease, and also like tightening of skin, these are all high risk patients. Coronary artery disease with associated valvular disease. Pure coronary artery disease is not a high risk. Then critically ill patients, like who are on ECMO, they are naturally very high risk patients. Then those are having anti-HLA antibody, like as madam was mentioning. And the next is HIV. So these are all the high risk patients. So coming to the contraindications. Indications we all know, because we know that when patient needs, he needs to be transplanted. Patient not willing is the first indication. If he's not willing, we don't list him. Malignancy with high recurrence, kidney disease worsening, recent acute coronary stroke or stroke with less than 3 days history, liver cirrhosis, infections, septic shock, limited functional status like bedridden and not having motivation to get to work, or just wants to just lay in the bed and is not motivated, psychosocial factors, or severe uncontrolled medical condition which limits survival. So these are all the contraindications. Now, I would just go through some pictures just to understand through our surgical pictures, just to understand how the transplant is being done. This is how an organ is harvested. And then once it is harvested, then we prepare the individual organs on the bench. Along with the trachea, it is brought. Then individual pulmonary artery, pulmonary vein and bronchi are then prepared. So that is the one which we prepare when the organ is kept in that ice bowl. So this is how a patient is positioned for the clamshell incision, or even if it is for a single lung transplant, for a thoracotomy incision, unilateral thoracotomy incision. We keep the lower groin also available, so that we go on ECMO, a veno-venous ECMO, or veno-arterial ECMO is the most common. And this is the incision, like we open up just like we do for any thoracic surgery. And it will be an anterior thoracotomy, because most of the time we don't do a posterolateral thoracotomy. And you can do bilateral lung transplantation with both incisions on either side if the patient is relatively thin and without cutting the sternum. This is the standard clamshell incision, where even the sternum is cut, and you can have wide access, and very easily the surgery can be performed. And you can go on a ECMO by cannulating the aorta and the RA. And then we first finish the right side, just showing it for example, finish the bronchial anastomosis. After the bronchial anastomosis is done, then we finish the pulmonary vein anastomosis. We prepare the cuff, the individual anastomosed to the LA. So we need to go a little into the LA body, and then we have to clamp. So then the anastomosis is done. So usually the LA to LA anastomosis is done, depending on, in some situations, if we don't get sufficient pulmonary vein, then we anastomose we join the pulmonary veins. These are all surgical maneuvers which are of not much importance here. Then after that, we do the pulmonary artery anastomosis. So the main important one thing is that whenever a lung is transplanted, we should not transfuse it immediately. That is a very common cause of getting acute pulmonary or a hyperacute rejection. We slowly get the blood into the lung over a duration of at least 5 to 10 minutes, and then slowly de-air the lung. We keep giving open the pulmonary artery and let the blood go into it, and then open the pulmonary vein. Once it is sutured, the suture we keep it a little loose, and we keep it, and over the duration of or maybe or 5 to 10 minutes, slowly we perfuse the lung, then only the lung will slowly get accustomed to the new perfusion. Your lung is a very sensitive organ, and if you just open up the clamp, then immediately it will go into vasospasm and then hyperacute rejection. So after this, so these are all the things I think which are more of a, I will not be covering much. There are two types of rejections. At least what happened is rejections were, before 2005, there were high incidence of rejections. But more and more after 2019, with more advancement in the science and also understanding of the lung transplantation physiology and all, rejections have come down quite less. And this is what we have been talking about, the basiliximab or Simulect and ATG, induction immunosuppression and maintenance immunosuppression. In Indian scenario, most of the time we are giving the induction immunosuppression with basiliximab and then continuing the maintenance. We tend to give a second dose of induction also on the 4th day. If a patient is badly infected, like is taken on an ECMO or anything, then we tend to not give the second one because it can lead to fulminant infections later on. But our basic thing is when patient is discharged, usually is on tacrolimus, mycophenolate and prednisolone. And these are the complications which are more surgical related: primary graft dysfunction, airway complications like bronchial dehiscence, stenosis, excessive granulation tissue formation, vascular complications, diaphragm injury, all more and more surgical aspects which we keep facing, and we keep taking care that these complications don't occur. Bleeding and thrombotic events have been a little less when we are doing them on veno-arterial ECMO, because ECMO when we do less heparinization. We can run the ECMO with a ACT of just 180 to 200, but when we run on a heart-lung machine, we need an excess ACT of at least 480 plus. So when we are doing on ECMO, our bleeding complications have been less. And airway complications, like most of the audience will be knowing about like necrosis, dehiscence, granulation tissue, stenosis, which keep happening depending on how the patient condition has been, and bronchial fistulas and anastomotic infections. So acute acute cell-mediated rejection and acute antibody-mediated rejection. So these are the things which are predisposing, like when we have high class 1 and class 2 mismatch, there is we tend to get that lack of induction therapy, younger age, and infections, associated infections. And like madam has almost covered most of these things, so I will be just bypassing this. Then treatment of rejections is usually steroids, like everyone is aware of, and whenever it is antibody-mediated rejection, we have to go on with plasmapheresis and steroids and all those things. So these are basically things which we surgeons also really don't understand much. So we keep skipping the slides whenever there is a talk. And so this is the video of the combined heart and lung transplant post-recovery. She was in our ward, and she has been almost, I think, 3 weeks after the recovery. She had to be intubated once. What we have seen is these patients who go on a combined heart and lung transplant, their circulatory system and the lungs are denervated. And what we could see is they suddenly go into a hyperventilation syndrome. And she was absolutely okay, and she was just sleeping, and she went into hyperventilation and hypoxia, and we intubated her and again brought her. So a lot of physiotherapy and lot of training, how to keep on telling her to do physiotherapy, so that she has to be remembered that she has to breathe properly. And especially being a small child, we no, can't expect her to cooperate with everything what we tell. So with this, I think we would like to conclude our talk, and any questions I'm ready to answer. Single lung transplant? Yeah. It's just a short video. I'll do. Yeah, you play it. So this was post-transplant only, and just we were waiting. We have done on a bypass, on a femoral, just like a ECMO on a femoral bypass. Immediately after transplant, if we see that the lung has become very pale and it is not looking very dusky, then we know that we are getting a hyperacute rejection. At least 10 years before, we used to face a lot of acute rejections, but of late, with more and more experience, acute rejection is not there, because one thing is we have got more experience with ECMO. Like when we did our first transplant, lung transplant, single lung transplant, we didn't have a proper ECMO machine at my previous hospital. It was a very old generation ECMO machine. So after we did a few transplants, then slowly ECMO machines, and all hospitals acquired ECMO machines after COVID. So now, after a lung transplant, what we do is we put him on a veno arterial ECMO. After the transplant is over, we check the oxygenation level, and he has a good oxygenation level. We convert him into venous ECMO. Why? Because we wait for at least 24 hours to see if he is developing any signs of rejection. And once we know the next day morning he is not developing any signs of rejection, and we are sure with all then we wean off the venous ECMO. Yeah, we have to continue, and we have to escalate our steroids and just continue the ECMO till the phase of acute rejection comes down. Yeah.
So the rule of thumb is, suppose except for graft versus host reactions, if that they can manage with alteration of immunity. But once somebody has got acute rejections, even though if you get past that phase, invariably they will end up with chronic reaction.
Yeah.
That itself is a...
Are we receiving any aid from government, a Jeevan Dan scheme?
Jeevan Dan scheme we had initially we were doing, sir. Of late in Telangana, what they have told is they are promoting more and more the government institution like NIMS to do the transplant organ, and more lung patients are getting registered there. And they have almost done 5 or 6 heart transplants in this last 8-9 months, and they are waiting for doing a lung transplant. So they are promoting more and more the government institutions. So that is what I was telling sir also. If you get yourself prepared from now, I think surely by the next year or so you should be prepared to be able to do. And like for example, in Arogyasri scheme also, they are roughly having a package for lung transplant roughly around 15 to 20 lakhs. Am I correct, sir? Yes. Around 15 to 20 lakhs. And that is quite a good sufficient finance for a lung transplant to be conducted.
after 20 lakhs, that could be sufficient.
Yeah, that could be sufficient. Yeah, because in as far as government hospital is concerned, we don't have the incurring costs of running a ventilator or running a ICU. Those costs are not added. Always in a corporate hospital, the costs of the ventilator, cost of the ICU, cost of the disposables, everything get added. The maintenance of the room, everything gets added up. But here we don't have those costs, so naturally it can be very well sustainable.
So last 6 months back, I attended as a panel member for RXC cases
Yes, sir.
from the pulmonology. They have included 2 professors from the government, 2 from the private colleges.
Yeah.
So when I went through the details of the transplantation, actually what is going on, again the Dr. YSR RXC is what before this government has came to me, the previous government has already taken a financial concurrence also to include lung transplantation in the Dr. YSR RXC.
Yeah.
But somehow it is not getting implemented. Now we advise them to go through the, because every lung is getting, every kidney and all the other
Yeah.
getting reimbursed or getting a YSR RXC.
Yeah.
So why not in the post-COVID scenario?
Yes.
That's what we insisted, and they also agreed. I think government will very soon will come with a RXC inclusion of the lung transplantant.
In fact, what we have seen, sir, post-COVID, the number of lung transplants have gone up, and heart transplants have come down. Why the heart transplants have come down is because of the very good drugs available, like the Vimada, which is sacubitril, and valsartan. So patients are not getting admitted to hospital with that medicine. What we are seeing is when we keep following some of these people, they are absolutely normal, but suddenly one day we come to know that he has just expired due to some arrhythmia or something. So they are very well functional class 1 or class 2 with those medicine. But in lung situation, they don't have any option, because their oxygen concentration, the requirement will keep on increasing, and they are naturally candidates for transplant.
So when you reperfuse the patient after heart lung transplant or the lung transplantation, what one you will open, the trachea or the pulmonary veins? Which one you're going to open that you take
when
5 to 10
when we
minutes?
reperfuse, we will be opening the pulmonary artery. We will partially clamp it, and slowly we will have to release the blood into it. And then we need to de-air the pulmonary circulation also.
Okay.
De-air the pulmonary, so that if air is there, it will again go into the left atrium. So we need to de-air the pulmonary circulation, and it can cause air embolism.
Air embolism.
So once it is completely de-aired, then we close the sutures completely.
So trachea opening and all that will be after the
trachea
very
will-
stabilization and all.
Yeah,
We
the-
know
the
anyway.
Trachea will be
Patient is the
anastomosed
next one.
first,
Yeah.
sir.
Okay.
Trachea and bronchus will be anastomosed first. And sometimes what we do is we use a vascular muscle pedicle
Yeah,
to
because
wrap around the anastomosis, so that it gives some protection from future any dehiscence or anything.
I have one patient of interstitial lung disease, sir.
Okay, sir.
And he had a end-stage lung disease. He is running around 90 or 80 between. And his daughter, both daughters are doctors. One of the doctors, she came from Canada and brought one ambulatory, mobile oxygen concentrator.
Concentrate.
So he is going around with that. The problem is when I was to make him to get ready for the transplantation, he was not convincing because he had some of the comments from the other
Yeah.
previous pulmonary, lung transplant recipients. And it's very difficult to convince them also.
Convince them, yeah.
So they want to take any number of medicines or now oxygen, but they're not able to get convinced.
So that is why even it is the same problem with our
Yes.
even in the corporate or private hospitals also. It is really difficult to convince, even for the best the person who is doing the more number of cases or more number of transplants also, it is very difficult to convince. So what the only take home message what I would suggest is, when we keep doing in the government hospitals, like suppose you have a patient who's not affordable, and you can really convince him. So when I was telling to Dr. Pathulu is, the best cases which we can take is a COPD patient. And COPD patients, you will be having n number of patients coming to your OPD. And if you can take them up and your number increases, So naturally, the number all over, all over the country, because we have a registry also now being maintained for lung transplant and overall, these news articles keep coming up almost every alternate day or every alternate week in different areas. Then naturally the people will get confidence. Once natural thinking untadi kada sir. When they are doing a lung transplant in Andhra Medical College, why we should be worried about getting it done in anywhere else? So that type of what do you say, thinking which comes naturally will give confidence to them.
But definitely after post-COVID, there's a lot of awareness was created.
A lot of awareness.
And most of the patients with lung fibrosis post-COVID, they're also coming and asking whether these lungs can be changed, or can we kept in new lungs, like that they're asking. But there is a change in the trend of the thinking of the patient. These unconvincible patients are only part of the thing, but majority they are now aware of that post-COVID scenario, especially.
But the best are like COPD patients. Really are the best patients because they are not immunologically we are not giving them any of those and their chest cavities are very well large and enlarged, and usually they won't be having much of coronary artery disease if they are young fellows. And IPF patients, what happens is chest cavity is very small, and they become a little difficult candidates, at least for the initial stage.
Sir, one last question, sir. Whenever we see any case of post-CABG, there is a metal clips there on the sternum. So how is the lung transplant patient looks like after taking X-ray, if successful?
No, he will not be having metal clips.
That's what I'm saying.
What we do is, when we do with a sternotomy, it is a transverse sternotomy.
Yes, sir.
Transverse sternotomy, so we usually have bands which can be, we approximate at the ribs.
Okay.
Sternum we need not approximate.
Okay.
Usually sometimes we take one wire, but if we approximate it with the bands, that is sufficient.
Is that one wire will be there, sir?
Which one, sir?
That one wire will be there?
One wire will be there.
Okay. Okay. Because we are fans in putting exams, so what is the X-ray?
What is the X-ray, yeah.
So thank you very much. Is there any questions from the faculty? Good evening, madam. Nice to see you here. Any take from any posted faculty members? Srija? Pravina madam, register. Okay. And thank you very much, sir. It's a wonderful session actually. You had made our eyes open for the new era for treatment lines. And you made us aware of what exactly we have the infrastructure and how best we can use it in the future perspective also. And I think we definitely this meeting has gone beyond our expectations to meet the next generation treatment lines, sir.
Thank you
very much. Thank you.
And next time, surely, as you asked for, we will arrange for a VATS talk.
Yes, sir. Yes.
Open Dorkatam, VATS, whatever, so that we will be coming to the more basic way.
We have number of cases, sir. Nothing to worry. But only thing is we can plan for a one VATS lobectomy as well on decortication, thoracotomy to decortication. Both cases we can plan if you are out. Otherwise, what the pathodo is still.
Not me to alone, no.
Because pathodo not only anesthesize the patients, he anesthesises us also. Yeah. The anesthetist with noble human touch also is a multi-pronged approach is there. He is anesthetist, pulmonologist and critical care is asset for our hospital, sir. Give him a big hand. Really, from the bottom of the heart, I really appreciate the pathodo efforts all the way. Even last time also, I insisted principal to take him to the existing vacancy because he is going to be big help also. And when we started thoracoscopy also, he is the one who ventured because he has experience in the Apollo hospital. So thank you very much. Thank you. Thank you, Nirza madam also. Thank you for a wonderful lesson. Thank you, madam. Thank you. Thanks all the faculty members, postgraduates, and mainly the technical people also. Technical people, they have arranged so much, and without any interruption, they have made all the technical transmission of the entire thing in a very coherent manner. Thank you very much, sir. Thanks, sir.